Good morning, everybody. And to the Yankee fans, I'm sorry. What I'd like to do is to start off and talk about our host who helped set this all up today, Mr. Al Kinel. Quick bio on him. He is the president of Strategic Interest, a continuing, listen to me, I can't even read, consulting firm, transforming healthcare. He works with providers, payers, collaboratives, and vendors to create a long-lasting positive impact through innovation. Strategic Interest helps organizations update strategy, select vendors, win grants, and deploy systems that improve performance, enhance population health, and value-based payment programs. Interoperability is the key, is what they do. Prior to starting Strategic Interest, Al worked for global professional services firms and helped as a leader in technology management for Xerox and Kodak Health Group. In all his roles, he helped transform industries through innovative strategies and solutions, process redesign, and collaboration to break silos. Al is a strategist, community activist, pioneer, catalyst who helps stakeholders address their strategic interests while attending larger community goals. Al has played his role to introduce and support major initiatives in his community, all of New York and beyond. Al has actively helps many nonprofit and associations, including the New York State chapter of HIMSS, through events and sharing of best practices to advance the effective use of HIT. And I can tell you that Al was the driving force behind today's event in helping. And I'd like to just welcome him up, say a few words here. Get us started, Al.
Thanks very much, Tony. Pleasure to be here, and thank you for the opportunity to lead this effort for the New York chapter of HIMSS on interoperability. It begs an interesting question. Why did I agree to volunteer and lead this effort for the New York chapter on HIMSS and interoperability? I love New York, especially the civilized part of it, upstate. I love a challenge. I have a passion for HIT and health information exchange and their impact on community health. And I believe in volunteering to help the industry advance through HIMSS and other groups collaborating. So here we are. Excuse me? Please put your phone.
Hold on a second. Mickey Chapathy? Is that you? Oh, hold on a second. Hey, Al.
What?
It's Mickey Chapathy.
Oh, Mickey. Thank you, Mickey. Sorry for the last minute add to the agenda, but I just got an opportunity to be here. Just want to share a few things. TEFCA changes everything. We need governance for AI, but how is not yet clear. And have a good time here in New York today, and thanks for helping us push the industry forward. To get us started, I'd like to read a section from a New York State DOH grant, RGA. Medical technology has advanced rapidly in the past 10 years, from robotic and laparoscopic surgery to drug-coated stents. In general, however, healthcare lags well behind other industries in investment and use of IT. Financial services has invested 10% of revenues in IT, while healthcare is around 4%. HIT is key to meet the challenges of increasing costs and quality gaps of healthcare, but it can also provide better and more timely access to information and sharing along the continuum. The delivery of healthcare in New York State occurs in many different settings, from physicians' offices to hospitals and from Manhattan to rural upstate towns. There's a crucial need for timeliness and standardization of data to transmit relevant info to healthcare providers. The diversity of settings, along with increased mobility of patient population, requires that standards be put in place so those providers can easily and securely access healthcare information. When was this? This was from an RGA in 2005 called HEAL 1. Does anybody remember HEAL 1? Alex, I know you do. That's very relevant here. So that's when HIE started in New York. It was pure fun to have the opportunity to work with a small group of leaders throughout the state to explore the possibilities and set a path forward and make a difference. It changed my career because it was the first time I learned how my professional experiences can be applied as a volunteer to help smart, well-intentioned, capable, secure leaders have more impact on our communities by working together, and how fulfilling it can be. There was ambiguity and confusion in the industry regarding ways to address these challenges. I studied the first 9 connecting communities around the US, and I joined Connecting for Health. I brought leaders from our community to Boston and Mid-Hudson to meet visionaries like Mickey Tripathi and John Blair to learn and to figure out how we can get their guidance. This helped Upstate to initiate HIEs. I also learned about the power of convening stakeholders to solve common problems. At that time, providers had different visions of the value and best approaches to leverage data to be provided by the not yet developed utilities called RIOs. Helping health systems and other providers improve performance with data innovation, including data from HIEs, became a foundation of our company, SI. New York has come a long way. NICE, the QEs, their boards and members have built an amazing network of networks. HIEs that add a lot of value for a lot of providers and the patients they serve. I sincerely thank you all for all that you have done. So this wasn't me, and I really appreciate it. Then came other opportunities. We are far better than most other states, and it has helped me and my family personally as we all use the value of the RIOs. But after HEAL 1 came HEAL 3, 5, 10, 17. Many of you probably remember those as well. 17, oh boy. That's the last time I pulled an all-nighter, and it will be the last time I ever do it as well, as we led the grant application in a program for a community health system with a variety of EMRs and a need to enhance communication with community specialists, nursing homes, and home health agencies. It's important because the setting at the time was a different time than we are today. The Community Diabetes Collaborative received $6 million in state funding to build and deploy EMRs, HIEs, pop health, care management, patient engagement to serve 3,200 patients with diabetes. Working with Eric Jacob and a lot of the people from Rochester Regional Health, it was Unity at the time. It was the most fulfilling healthcare project of my career, as it leveraged the HIE and many other tech to yield a positive impact on outcomes. Why it's relevant today is the following. The common interop dilemma at the time was public or private. People remember that? People thought there'd be a silver bullet, pick one. We thought it was both, working in harmony. I remember vividly a sleepless night before our meeting with the state to justify why we needed a private HIE for the health system to connect to the public HIE. We needed data scope, granularity, timeliness, and quality that was beyond the capabilities of the RIO at the time. In fact, we worked very closely with the RIO to deliver the best interop strategy available through both Rochester RIO and DB Motion, a platform we use for our private HIE. The private HIE was incredibly valuable at that time and for many years. But interop strategies should change as needs and capabilities do as well. The health system migrated several EHRs to Epic. The services of the RIO increased value. The private HIE was retired for that particular use case. Other health systems still use them, and we need to figure out how to go about moving forward. Many providers have developed great interop strategies and capabilities, and I'm excited to hear about them today because we have some great providers here from upstate and downstate. The landscape has changed and many of the problems described still exist. There's still ambiguity and confusion. What should health systems and other providers do now to optimize interoperability? That's the purpose of today. We have a great lineup of experts to share perspectives, bring clarity, and help each of us get smarter to contemplate the question. Standards are more mature, EHRs are more mature, regulations, tech capabilities are stronger, HIEs, cures and TEFCA are real, QHINs are here. Needs and uses of data have also enhanced. We also have to find a way to enable secondary use cases that are valuable to society, like helping us come up with new drugs. We need to shift from a situation where a variety of utilities provide threads of connectivity and help us create a quilt that can cover all of our needs. I'm thrilled now to introduce our keynote, David Horrocks, CEO of New York eHealth Collaborative. There's no one better to summarize the interoperability landscape, federal regs and standards, direction, and approach of New York State, changes coming to the statewide health information network, SHIN-NY, and how HIE utilities will complement other solutions to build that quilt, to help providers build the quilt that works best for them. Following his remarks, we'll have a series of panels to provide context and information to help you design your quilt. One on existing interop tools, enablers, and capabilities, followed by a panel with 4 of the approved national QHINs, and then a panel with providers from New York City and the civilized part of the state, Rochester, to get their perspectives on designing their quilt. But first, David.
Well, thank you, Al. And Al asked me to on the topic of.
You can
Luckily, it fell down.
Unused.
So thank you, and Al asked me to. Better? Yeah. All right.
Oh, better.
Asked me to speak just briefly for 15 minutes or so on the topic of TEFCA and other government initiatives to enable interoperability. And I appreciate the opportunity. It is such a good day to thoughtfully reflect on such topics. So I have 3 points, really. One is on TEFCA, status of that. The second is the state's efforts and the SHIN-NY. And then a third will be on what I think is a barrier for further progress. So we'll just jump in. So the first point is that TEFCA is gaining traction. And at the national level, I think it's where most of the action is. We've had national networks for quite a long time, and actually on a transaction basis, those other national networks, especially what runs across care quality, are still I think several orders of magnitude higher in transaction numbers than TEFCA, but I don't think that that will be the case for long. And I do think that paying attention to TEFCA is what we need to do. Now, most of you probably have a good grasp on how it works, but Zoe sent me a couple slides, and I thought I'd just run through a little bit of how TEFCA does work. TEFCA operates under the sort of auspices of what we used to call the Office of National Coordinator for Health IT. And since that was a mouthful, I guess, we made it the Assistant Secretary of Technology and Planning or Policy or something. So that it's very catchy. So TEFCA operates under their auspices. They have contracted with a designated entity to oversee the network for them. That designated entity is the Sequoia project, where Zoe is and where I've had the privilege to be on the board for the last number of years. The RCE, Sequoia, organizes the policies and standard operating procedures for the network. Now, really, the heart of the network, you might say, are these organizations that directly participate in the network. They have to be qualified to participate. There aren't that many of them. There are 7, I guess, at the moment. And we call them Qualified Health Information Networks, or QHINs. And a good number of them are in the room today, and I'm sure we'll hear from them shortly. The QHINs themselves have signed up participants. So he tells me there are 112 as of a couple days ago participants that directly work with the QHINs. Some of them are networks themselves, and there are another 1,600 or so sub-participants in the network. So did I get all this about right? So, okay. So in TEFCA, if you were familiar with Care Equality and that network, which in fact Mickey Tripathi was very instrumental in getting off the ground, this is functionally very, very similar to that network. It is, however, government endorsed. It's government endorsed because we passed a law, or the Congress passed a law in 2016. We were talking about this in December of 2016, one of the final bills of the Obama administration. That was the 21st Century Cures Act that directed the ASTP, formerly ONC, to either start or support a network that would serve this purpose, and they decided to start one. So if you're doing the mental math, that's 8 years. This is not quick work. This takes time, and it will continue to take time. I will admit that I've been maybe a bit optimistic on timeframes for our national network progress, but I do believe it is an inevitability, and that progress, barring something unexpected, big changes in the direction of one of the future administration, I think that it is an inevitability. So I included a picture of these are all of the QHINs. As I said, some of them are in the room today, and we'll hear from them. I'd say they each have different strengths, and they bring a different basket of services to the market, but all of them can move and transport data equally well. TEFCA, the Trusted Exchange Framework and Common Agreement, is primarily about the movement of data. It is not in and of itself about the aggregation of data, but QHINs are, at least some of them, do aggregate data and provide analytics services and do other value-add things on top of it. So an observation I have about our current state is, and this is very much an opinion that others might debate, one of the reasons I think that TEFCA is an inevitability is the support that we're seeing from EHR vendors. And I think that's crucial to the adoption. I think it's crucial to the workflow friendliness that clinicians or care managers or others will experience in using the network and in interoperability tools. And we are seeing, even in the last week, several announcements, I guess, that demonstrate that the major EHR organizations are backing TEFCA. So I think that is a harbinger that broad participation will come, even if it does take a bit of time. One more thing that on TEFCA that I think is important to understand is that the purposes that we can use the network for are limited, but growing. And the major purpose that people use the network for today, of course, is for treatment. If you are paying close attention to the trade press, you know that what treatment means is not exactly the same between maybe one organization and the next. And that is an issue that I think we do have to resolve as an industry. And that'll be part of the point number 3 in just a minute. Just recently, we've seen some additional purposes that have been approved. These are approved as, what do we call them? Exchange purpose SOPs, I guess. So the public health SOPs have just been finalized in the last few weeks, and that's very exciting, very important. Not all of the finalized purposes are required, and I think this is also a very important point to understand. If you participate in the TEFCA network and you receive a request for treatment, you have to respond to that. You're obligated under the terms of your participation agreement that probably flows down from your QHIN. For some of these other purposes that we're building out at the moment, you're not required to respond. And I think we can probably guess that until we're required to respond, the network won't live up to its full potential, and that because many will not. So we're making progress. 8 years in, I think it will continue to be slow. EHR vendor support, I think, is crucial and makes this an inevitability. Have to work hard on these standard operating procedures and these exchange purposes. That's my TEFCA point, and I'll move on now to state efforts. The New York eHealth Collaborative, we are contracted by the state. We're the designated entity for the state to oversee the work of the SHIN-NY, which I'll describe how the SHIN-NY works. Most of you, again, probably know that. The SHIN-NY, like TEFCA, is not an organization per se. It is a network in which organizations participate. The business end of the SHIN-NY is organizations that have been qualified as direct participants. We call them qualified entities, or QHINs, and there are 6 QHINs in the state, at least one of which is in the room today. There are participants that work underneath of those QHINs, and there are about 19,000 of those participants. QE, what did I say? QHINs? All right, that was a Freudian slip, and I'm gonna show you why. The purposes for which the SHIN-NY was established also began with treatment purposes. It was that clinician who was in front of a patient who needed medical history. That's the stuff that really got people excited in the beginning. But those purposes have also been expanding. And I'd say that public health purposes are increasingly very important. They're a lot of our focus. Supporting the NIHER 1115 waiver that our Medicaid team is rolling out is one of those what I would deem a public health purposes. Now, as I describe this structure, somebody will be like, "This sounds familiar," and that is true. I think that the governance model that was adopted federally is very similar to what New York had been using and was in place. We have our version of a national coordinator. That is Ann Skatine at our Department of Health. We have our version of a designated entity, and that is New York eHealth Collaborative, where I work. We have our version of QHINs. They're QEs. Very easy to mix those two together. So our QEs do a lot more than move data, though. They are all data aggregators, and they are all doing value add things on top of that data. They do, sure, they move a lab result from point A to point B, but increasingly they are helping a practice that's in a medical home understand their performance vis-a-vis their peers. They are delivering notifications about hospital encounters to care managers. They are supporting public health purposes, and we'll probably hear a little bit more about that today. All right, so where are we headed with the SHIN-NY? We said we are modernizing. We are working hard to modernize, and we have 3 strategic priorities in the modernization. And these have been given to us by the Department of Health and also with the input of many stakeholders, including some of you in the room. Our priorities are first, statewideness. We need to be able to provide seamless statewide services across the state of New York. The Shiny is very good at serving communities. We have these 6 regions with our QEs, but when we have to try to pull the data together for something like the 1115 waiver support, or we're right now practicing aggregation of the social determinant of health screenings that will be a big part of that waiver, that's not a strength of the current model. We're modernizing to fix that. We are secondarily trying to get more efficient, and we're trying to get more efficient at the movement of data so that we can put more of the resources into the value add that happens on top of the data. And then the third priority is, you could say, continuing to support communities. We're going to continue to have a QE-centric model for the Shiny, where we build on the strengths of these regional organizations. So as with TEFCA, that after the Obama administration passed it, it's like 8 years on, we're still working. It is slow, it is hard. That is also true for reform of the Shiny, putting new policies in place and trying to shift the way that we work. In a thumbnail, though, of what we're trying to do with reform here is on the screen. We are trying to free the data and not have these sort of regional repositories where a participant has to only work with the local crew because they're the only ones that have access to the data. We want participants to have choices. They can choose any of the 6 QEs, and that QE would have access to the data necessary to serve them. They could work with a second or a third QE for services that they are good at. And this is how TEFCA works. There are no separate regions where you have to work with the New England QHIN. No, QHINs have access across the board. Reform is going to facilitate those statewide services I described, such as the 1115 waiver, but there's many more that we want to support. We want to support the epidemiologists when the next, and it is inevitable, right, the next public health crisis or emergency hits in New York. We want our epidemiologists to have quick, accurate access to information, population health statistics, and information that's what I would call hydrated or uplifted, meaning there are reportable conditions, and we do manage to get those reportable conditions up to our public health officials, whether that's a respiratory illness or other infectious diseases. But uplift would say we're delivering this respiratory illness information with chronic condition flags like asthma right on that report, so that our public health officials can understand and react more quickly. So the reforms, I believe, will be very good for participants. It'll be very good ultimately for patients, and they are now required. This move is required in regulation in New York. So I have a slide. I'm not going to try to get into the particulars of this, but there's so many elements to trying to reform. We have to move to a single statewide participation agreement. That's how TEFCA works, right? There is a CA and TEFCA, the common agreement, and we need the same in New York. We need to have a common agreement that we work from. We need to have a single consent registry for patients so that today, most of the consent happens in 6 separate repositories. That needs to be statewide, and we're working hard to get there. We need the gateways that NICE operates that help the QEs move data between each other. They need to be much better. We need to define what is core Shiny data more accurately so we can improve the quality of what's submitted and what's available to participants. So all of those things are in flight, and I hope that you will see exciting things in the Shiny soon. So I have one more point. I have enough time for one more point. Yeah. So, and that is what is holding us up from better progress at a national level and at a state level? And I think it is the privacy of patient data, both at the individual level and at the aggregate level, which you might really say a data use question. We have not solved this as an industry, and we have to. I have a picture here that is a conceptual model, if you will, of where I think how I think we can protect patient data in the exchange of information. Really, there are three places where one might do this, right? There's the requester. You can make sure there are policies and rules around making a request for information. There's the intermediary that's moving it. You can have policies and protections there, like a global opt-out, for instance. And then there's where information is held or originates, and you can have rules there. And the SHIN-NY has focused, where has the SHIN-NY focused on those three places? What?
The intermediary?
The SHIN-NY is the intermediary,
Yeah.
but our policies for protecting patients have been at number one, believe it or not. It has been really focused on the data requester. You have, before you're allowed to ask for your patient's information, you got to get them to, like a wet signature on a form. And that form then has to go into a registry, and now you're allowed to peek. I think it's the wrong place. I don't think that's the right way to protect patient privacy. It creates burden for providers. It creates confusion among patients, and it doesn't do anything for bad actors. Like if you're just going to attest, oh, I got the signature, like and you're a bad actor, that does nothing. It's like asking at the door to the store just to confirm you didn't shoplift. Like it doesn't do anything. So we need to fix this. What does this mean for I have a picture. You're going to understand what this picture is. You've all experienced this. This is what consent is.
Sure.
We are relying on something that is not meaningful. It does not protect patient privacy. I know you've all experienced this. You go in and you sign 3 times. You have no idea. That is not an informed consent. That is not a process that's me. Why are we doing this? Why? It was just checking boxes. We have to do better than this. So this is what, if you really care about privacy, with the theme of the day, this is what this means for patients. So in my opinion, this is not addressed nationally very well. I know that's not an opinion shared by everyone, but I don't think we've addressed this nationally. I don't think it's well addressed in TEFCA. I think we should solve this in New York State and apply it to TEFCA too. We should give patients the right to, at that point of release, a patient should have the right to say, don't share my data, other than the normal health operations, don't share my data elsewhere. That should be a right that a patient has. And in the case of sensitive information, and everyone's very concerned about sensitive information, honestly, post the Dobbs ruling, that choice that a patient has should be a very carefully administered choice. It should be an opt-in choice, probably. But in other instances, it perhaps is an opt-out choice. Let's make this easier for patients, but give them a real understanding. At the point of exchange, we should give patients a global opt-out opportunity, and they do technically have this. But for it to work today in the SHIN-NY, they'd have to go 6 places to opt out. And then that doesn't count the QHINs in TEFCA, and it doesn't count the other national network activity. Patients should be able to do it one time, and boom, I don't want you to do this. I want it blocked. That is a patient-friendly thing that we should implement in the state. And when we do that, when we get all of our networks hitting against a common consent registry, we can also create a log of each of those information releases, and we call that an accounting of disclosures, right? Or just a report for a patient, how your information was used. Not many people ask for these in my experience, but some do. And they should be able to get that one time for the state. Let's implement that. And then that first place where we put all this energy of collecting forms, let's stop. Let's say if you've given consent for treatment, then your doctor, your care manager, your clinician can request the information. We'll protect it at these other points. So that is my those are my 3 observations on government support of interoperability, Al, and happy to turn it back to you in the panel.
Thank you very much. Better. It's not just because you're in the position now. I've known you for a little bit tangential. One of the most impressive presentations I've heard was when you represented Chris and she, and all the HIEs were running scared because care quality was. They were trying to put up. Here's why you need to. You know, most of them were saying, "Don't listen to care quality. Stay with the HIE." You said we need to openly embrace it, understand it, figure out how we can make it part of what we bring to our providers.
Yeah.
As part of
Well, thank you, Al. I you know, and I didn't emphasize that enough in the shiny reforms a minute ago, but we will work to make the shiny and our QEs complementary to TEFCA. We are enthusiastic about TEFCA. We wanted the privacy to get figured out, but we can have very efficient pipes. We can put more of our resources into those value add things.
It's
That would
hard
be-
and it's complex,
so.
but thank you.
Thanks.
We'll wait for questions till the end of the first panel. And the last point you made did make us a little bit trouble in time, but we're okay. We'll be okay. On that note, we tortured ourselves with how do we make this time work and have breaks. But if we have breaks, it just won't work. So if you need a bio break, please, men's room's right there and wherever. But we're going to try and just go from session.
Women.
Is what I was going to ask, where the women. Great. Now we'll go to our first panel. So the story continues. You know, this is a story that is different than it was on existing enablers that are helping providers deliver interoperability. And so as the storyteller makes no choice, soon you will not hear his voice. His job is to shed light and not to mess. But one of the masters, Virginia, is going to come on up and do this. And it's just a conversation. So Virginia has over 34 years experience championing interoperability and implementing interop solutions. She has a long tenure at New York Pres, now serving as subject matter expert in interoperability and regulations on the Interop team. She also serves on the faculty at Columbia University, leading the Department of Biomedical Informatics, Health IT program, and chairing HL7 Fire Lab. I guess you belong here. She's a leader in the standards development space, serving as part of the HL7 community since '94. She is currently board secretary, serves on multiple committees and task forces, and is a founding co-chair of the Patient Empowerment Work Group. Virginia also served as test monitor in numerous IHE Connectathons, received degrees from NYU and Stony Brook. Finally, Virginia is proud to be a member and an artist on the Walking Gallery of Healthcare. Let's hear it for Virginia.
So welcome, everyone. I'm very excited to be a moderator here because I get to ask the questions. And if anyone knows me, they know I ask the questions, right? So quite fun. And I'm really excited because I'm going to get to talk with 3 interoperability leaders in our country. So I want to introduce Zoe Barber from the Sequoia Project. And I don't have the big, beautiful intro. But what I want to tell you is Zoe Barber has been around a long time in interoperability. And while she is serving a really important role in our country in getting this national network going, she also has a lot of history in New York in helping with the shiny. So she knows us well. So thank you, Zoe. Yes. And also David, again, who has introduced himself. Again, many years of experience here in terms of moving interoperability forward. And I also want to introduce Todd, who we know locally. Todd has been part of Healthix since, I don't know, since I was born. So, yeah, so doing interoperability right there locally, you know, where the rubber meets the road. I'm excited with each one of you. And I thought it might be helpful for everyone to understand a little bit about who you, what organization you work for, just something about kind of the mission of what organization you work for. So start with Zoe.
Okay, great. Hi, everybody. It's so great to be here. Thank you so much, Virginia, and to the New York HIMSS chapter for having me. I currently am the policy director at the Sequoia Project. And previously, as Virginia mentioned, I worked for NICE and I was at ONC for several years, including at in 2016 at the beginning of TEFCA. So I've been doing TEFCA for the full 8 years that it's been around. And at the Sequoia Project, we are a 501c3 nonprofit public-private organization, and we bring together trusted stakeholders from across the industry to collaborate on challenges that are common, across different organizations, and work towards bringing together productive and real-world solutions to those problems. And so we do that under our Interoperability Matters initiative, and we have several work groups that are open to both members and to the public, including information sharing, privacy and security, data quality, pair-to-pair. I could keep going. And then on top of that initiative, we were actually originally formed over 10 years ago to steward the first nationwide health information network, which is now known as the eHealth Exchange. And then a few years later, we, with the help of our founding members, we also launched Care Equality. Both of those organizations today are privately owned and operated. But because of this past experience and our reputation and work among the industry, we were selected in 2019 by ONC, now ASTP, to be the recognized coordinating entity for TEFCA to help to implement and to oversee the program. And that is a large part of my role today as the policy director for the Sequoia Project and leading policy work for the TEFCA.
Thank you very much. And David?
So in the New York eHealth Collaborative, I already described a little bit, and it's very analogous to the Sequoia role as the SDE. We are contracted by the state to look at the policy matters, the strategy for the SHIN-NY, accountability for the state's own investment, how that spending gets used. And then the fourth thing is when there is statewide tech, like the glue that holds the QE transactions together or statewide MPIs, we operate that statewide technology as well.
Todd?
Good. So we're going to describe us as a cog in the wheel, but you can see we're kind of going down. But we're very focused on the community. So we're a regional HIE. We're very large. We're one of the largest in the country, but mainly because of who we serve: New York City, Southern New York State. And as David talked about earlier, our role is kind of pivoting to less of moving data. We connect data with over 9,000 provider organizations, including health plans. And we serve that around 20 million active patients within New York today, which is fabulous. But our role is changing more to focus on analytics. How do we leverage this data to be actionable? How do we get it into the clinical workflow? So it's not just the pipes, the moving of the data, but how do we make it so you can leverage it in actually providing healthcare?
Thank you, Todd. And kind of on that note, I wanted to, and because of the title of our panel, we have the word existing tools and enablers. And I wanted to ask a bit about that and ask what existing functionality and tools do you provide either now or in the near future that really will help enable interoperability?
Yeah, sure. I can go first. And lucky to have been set up a little bit by David describing the TEFCA. As he described, we are a nationwide network, and we are backed by the government, led by ASTP, and that public-private collaboration has really been very beneficial so far. We've also had the opportunity and a lot, it's been really great for us that we've been able to leverage and to build on all of the successes of the networks that have come before us, and also to learn from the obstacles that they have faced. Today, the TEFCA supports 3 different transaction types. So there's document-based query exchange and push-based exchange, which we call message delivery. And that's done using IHE-based protocols between QHINs. So the QHINs are brokering that exchange. And then also recently this year, we released an SOP to provide support for facilitated FHIR-based exchange. So that is an optional transaction on the network, and participants and sub-participants have the opportunity to connect directly to each other using some of the services of their QHIN, but to connect their APIs directly to each other to exchange using FHIR. And in the first couple of years, as we're growing, we really wanted to kind of meet the industry where it is today. And so we've provided for a lot of flexibility in how those FHIR mechanisms work for authentication and registration and authorization. And we're moving towards having a more scalable and standardized network approach towards FHIR that, eventually we hope one day will actually be required of everybody on the network. We also, the RCE, we don't store any data, any clinical data, but the RCE does have a directory of endpoints. It's an R4 organization-based directory, and the QHINs have access to that directory, and they can provide that information down to their participants and sub-participants for routing of information and finding where records are. And as David mentioned, we actually have, I believe it was 1,700 connections in the directory today that are connected to a framework agreement. And that represents another 8,000 or 9,000 actual facilities and clinical sites that are parts of those various connections. And that is growing daily. We've had, I think, 3.5 million documents exchanged on the network to date. And that number, again, it's growing exponentially. And then, of course, the reasons for exchange, we have 6 exchange purposes, again, that David showed earlier. Those are sort of the broad umbrella exchange purposes: treatment, payment, healthcare operations, individual access services. And then underneath those umbrella exchange purposes, there are also various use cases, which we like to call our paved pathways, that have more, parameters and requirements around a certain exchange purpose. We've recently created a definition for TEFCA required treatment, so it's a slightly more clarification on the broader treatment definition. We also have several use cases under healthcare operations and public health, and hope to build out those paved pathways more over the coming year.
Thank you. David?
Well, I'll focus on what we call the statewide data infrastructure and the data lake that NICE has been building. Really started about 2 years ago. The data lake has it's a thin layer, not a great breadth of records, but it is broad. We are trying to have statewide information aggregated in this data lake. It has basically 8 customers right now. Those customers are the 6 QEs, the Office of Health Insurance Programs, or OHIP, our Medicaid team, and then the epidemiologists at DOH. And today that data lake holds lab results, a pretty good breadth of lab results. The source of those is the 6 QE partners, and it holds ADTs, the admission, discharge, transfer data from the hospitals, all the hospitals in New York. And we have a lot of test data for the 1115 waiver. Soon that will be, hopefully in January, that will start to be live data. It will be all of the social determinant of health screenings that are, what are we calling it? Not SDOH, we're calling it health-related social needs, HRSN screenings, and all of the copy of all of the referrals that get made as part of that program and the assessments. And that data will be available to the QEs to deliver back to care managers so they know what is going on for their patients. That data will go up to OHIP into their own data warehouse so they can do all of the reporting that's necessary with CMS and hopefully convince CMS we need this thing to keep going because of all of the great work that gets accomplished. And then hopefully when we have a hero, it'll be a source system for the hero as well. So maybe that'd be a 9th customer. So we're very excited about that. We'd like to grow the purposes of that data lake. It will include increasingly more of the data the state has already collected, and we can merge those things. The data lake's big function is to merge data sets, the clinical information with things like Medicaid claims or enrollment data in other programs, put it together. You can spit it back out as an enhanced data set, or in the case of the epidemiologists, often it will be as a limited data set where they're not maybe getting identified data, but they're getting geographic data and trend data on things like chronic conditions. So we're really excited about that statewide data infrastructure and working hard to build it out.
David, can you just remind me, what do you mean by hero?
The Health Equity Regional Organization. It's an organization that will do a lot of the analytics support for that, the big 1115 waiver, the NIHER program. And I don't know that the state has exactly announced who will do that work yet. I know they're in conversations with folks who will do that. And they will inevitably need data, source data, and we want to make sure we're able to provide some of that to them.
Excellent, thank you. And Todd?
So we're kind of like the foundation to the house. If you haven't seen that theme already, I think the QHINs, the SHIN-NY as a whole depend on the organizations that actually collect this data and bring it up. So we've focused a lot on high quality data, making it even higher quality data, terminology mapping, but you talked about the services we offer, and really those are focused on the community that we serve. So as much as we're still in the business of collecting the data today, we really do focus on kind of 3 major areas: data delivery, data retrieval, and data discovery. So within our retrieval, the delivery, we talk about sending out real-time alerts, which is something that the national exchanges don't do and TEFCA doesn't do currently. We focus a lot on providing high quality certified data to do HEDIS calculations for the plans. And then we do work with large organizations just to pump them full of data, which they can do their own analytics. On the retrieval side, we support the basic querying of Healthix across the state, but also within our customer base. We have a clinical portal, which we've really expanded and tried to integrate very close or tightly in with EHR vendors like Epic and Cerner. We've included the PMP, prescription monitoring program, as a really tight integration. And within the context of the patient, Todd Rago in this case, you can just pull the HIE data into your view within the EHR of your choice. So we've really been focusing on how we do that tight integration, knowing that clinicians really don't want to take the extra few seconds or few minutes to look elsewhere. If that's their major tool, you have to kind of be present within their tool of choice. So a lot of focus on how do we best serve our customers so they can serve their patients in healthcare. But those are, and I'll talk about data discovery just briefly. We've been building dashboards really created by our customer base So behavioral health organizations, which have kind of been overlooked in meaningful use initially, and I think they're getting more attention under the waiver and things that are happening in New York today. Community-based organizations, FQHCs, these are the organizations that are really making a Herculean effort on the ground to change healthcare in New York. So we've built dashboards to really help them access this data more efficiently, in a more meaningful way, so they can leverage it in the work they do. And some of it's on aggregate reports, but also some of it's at the point of care as well. So we're really just working with them. They're the experts. How do you want this designed? How do you want us to supply this data to you? And we're really excited about that type of work that we're doing today.
Thank you, Todd. And you mentioned patients. I want to say that I sent in the paper form to Healthix asking for my data, and I found data that's from when I was very young, a very in-depth amount of data, things I didn't remember. So
it's funny, we don't have a fax machine anymore, nor a copier in our office. We feel like we're going high tech. And we did a year ago launch a patient portal, which I would encourage every New Yorker. It's a free public service funded by the state, obviously. We use Clear for identity proofing, so it's highly secure. We do know who you are as you come in. And it really does open that up. So you don't have to submit a paper form any longer. You can just go to a website, My Health Record New York, and ask for your records. So I encourage you all to take advantage of that.
very good. So it's Halloween.
Oh, no.
So I was thinking of, trick or treat and interoperability. And, while I would like the treat of interoperability, I spend a lot of time, as well as many of you may, worrying about the trick. What could possibly go wrong? So so the question I have for all of you is, how do we, ensure that data is not inappropriately used, that the availability of data isn't inappropriately shut down, that we don't have, the wrong data, just data quality errors, gaps in data that mislead clinicians because they don't even know that encounter existed, or stale data, duplicate data that overwhelm our clinicians, or just poorly coded data so it's just unreconcilable. So I wanted to ask each of you, how do we tackle these difficult things to make sure that it's treat and not trick?
Yeah, that's such a great question. And I'm really glad that you asked that. This is a topic that we have had no shortage of conversation on over the past year. And in TEFCA, trust is kind of the cornerstone, the building block of the entire network. It's literally the T in TEFCA. One of our QHINs likes to say that without trust, you just have EFCA. And so, we understand and we've heard from our QHIN community and from our stakeholders that when, we are exchanging data at this scale and with partners who may not otherwise have relationships with each other, they may not otherwise know each other, that we really need to have a very rigorous level of compliance. And so we've taken that very seriously, and we've had, again, the support of the federal government to help us. And we've also had our early QHINs and their participants and sub-participants who have participated in helping to shape and influence the policy so far, which I think has really built a very, collaborative approach and a lot of camaraderie and trust within the community of QHINs. So over the past year, some of the things that we've worked on is first tackling the definition of treatment. This is something that has come up a lot over the past year. The HIPAA definition of treatment is very, very broad. It's very subject to interpretation, and it's actually intentionally subject to interpretation. The law was written that way so that covered entities could interpret, locally based on, their compliance priorities, who to respond to, and what they consider to be treatment. And so what we've done in TEFCA is to actually slightly narrow, but really more clarify what treatment is, and specifically what types of treatment you actually are required to respond to. So using the HIPAA definition as a base, we've essentially said, there are certain provider types, covered entities that are doing certain types of activities and making queries that are in connection with or intended to inform treatment with a patient, whether synchronously or asynchronously, but that there actually has to be the intention of having a licensed individual provider, so a human in the room to provide those treatment services. And so, the whole community, again, agreed on this definition, which we plan to expand over time. But then kind of following on the heels of determining that definition, we've now created a vetting process so that we actually have a systematic and structured approach to ensuring that anybody who comes in and says that they are providing this TEFCA required treatment purpose and that they plan to, assert queries for this purpose, that they actually have to go through a process where they can prove their eligibility and prove their use case, and the QHINs have the opportunity to review the evidence and to raise any concerns, and then to have a discussion in an open forum about any of those concerns. So this is something, we are just putting the finishing touches on this vetting process this week, and we'll be releasing something next week. And then we plan to expand it so that every exchange purpose that will have a required response in TEFCA will actually go through this vetting process as well. And we're really hopeful that that will help to, again, build trust and, just continue and enhance integrity of the network.
Thank you. David?
Virginia, I might say trick or treat. It's maybe cooperation and competition, and getting the balance right. I think market mechanisms are really important. The topic you had asked me to speak to was government intervention in interoperability, and we're doing that because of market failures, though. And the market failure that worries me is availability of data. We have lots of competition that makes us stronger. We have QHINs in the room who will be competing with each other. We have Sinai competing with New York Presbyterian, right? And that makes better. We have Epic competing. I don't know if there's any Oracle people here today, but they're competing, and that makes us stronger. As the shiny overseers, we want the QEs to compete with each other as well and strive to be better. But it's so tempting to compete by holding on to the data, and that's got to be anathema to us. We have to make the data freed up, and that can't be the thing we compete on. I think that regulators and really those who are in the industry watching, setting the policy, we need to really make sure that we're not competing on the availability of data, that is freed up to be used in ways that benefit patients as we try to get the benefits of competition in markets.
Thank you.
So it's very interesting. I like some of the themes here. I agree with a lot of what's been said, but healthcare is still a very local thing. So, you still end up going to the providers where you live. You do occasionally go on vacation, get injured, don't come up to New England or Northern New York and fall skiing or something and break your leg. It's not good. But anyway, bringing those medical records together is a problem, but it's really only a small percentage of the healthcare problem of bringing records from away together. I think the majority of the issue is more local, and there is that same challenge locally on how to aggregate those records. But there's this big theme of trust, and I think, I used to work for the HIE up in the state of Maine, and the whole framework, one HIE for the state, small population, about 1.5 million, was built off from trust. It wasn't a requirement to connect to the HIE. It was just something people did for the right reasons. And so I would put out a statement that we want to be careful in New York not to overregulate things. I think it's really important when it comes to privacy and building trust. that there are guidelines established. There's good governance and good cooperation. But I think sometimes if you overregulate, people start to lose trust a little bit and feel like they can't gain trust in the system. So it's just something to keep in mind. There's a balance there. If I lost trust as an organization, no one would share data with me unless they were mandated. And we have a large group of ambulatory practices, 5,000 plus out of the 9,000 that send us data, and we can't afford to lose the trust in them and how we handle the data. So I think the governance that David's providing with NICE is really critical to this from the Department of Health, how we establish and maintain that. We mentioned competition. Everyone competes against me. Yeah, we're the ones we're the nonprofits that have been in this business forever. I compete against Epic, Cerner, and how can I do that? Not very well. I compete against healthcare organizations, because the tendency is, if you do control the data, as David said, if you capture that data, and EHR vendors want to hold on to the data, the hospitals want to hold on to the data, the practice feels like if my data gets into the hands of a qualified entity or an HIE, that they're going to poach my patients and take them away. These are valid concerns. So I agree with David, we do have to free up the data. And in the state of Maine, that's what they did. The largest healthcare systems got together and they agreed not to compete over data. And it's hard because they occasionally want to move off the reservation and say, I want to hold my data tight because that's how I hold my patients to me. But to David's point, how do you treat the patient? How do you treat your customers is what attracts them to you. So if I can bring it back home, to keep people attached to Healthix, I have to provide good customer service and high quality services. And leverage the data we get holistically. And as people know, in New York City, we have the Bronx and Healthix. So the Bronx is a little bit fractured, but bring that data together. We do have services in the state that do bring the data together. And I agree with David, we have to improve those. So the trick or treat for me really quick is, it's funny because the more mature customers say we provide too much data. And you mentioned duplication is a big problem. And so I agree, duplication, how do we dedupe? And as data becomes held or is held by many organizations, how do you deal with that duplication problem? Because we are going to flood the user, the clinician, with too much data, and they only have a few seconds and they only are looking for one thing. So how do we refine the data? So it's kind of a blessing and a curse that we have to solve. I don't know if you put it in trick or treat, but I think too much data is a trick and a treat for HIEs.
One of our clinical experts and informaticians in NYP, Cornell, and Columbia said that the CCDA is kind of like a passive-aggressive standard. And yeah, so my next question is at New York Presbyterian, we're trying to provide IT for New York Presbyterian, Cornell, and Columbia, and interoperability, and we really want to do this well and participate well in interoperability. And so as a result, we are connected to SureScripts, where we get to do direct messaging and e-prescribing. And we also have been a longtime member of Healthix. We started when it was called NYCLIX. I think we were part of another QE, but now I think we just have Healthix. We also have Epic Care Everywhere, and we have Care Equality, and we have eHealth Exchange, and we also have a whole smattering of HL7 version 2 and CDA interfaces to public health. And we're really interested in streamlining things. And even though I'm here as the interoperability witch, I do not have the magic potion for this. But what I would really like to see is I'd like to connect once, and then I would like to participate in interoperability and obtain interoperability in a robust and comprehensive way. And so I want to ask you, because I've heard I want to connect once to TEFCA via our QHIN, and then magically everything else should happen. And I wanted to ask you, like, one, am I out of my mind? Is this achievable? Is it possible? And then two, I want to ask if it is potentially achievable, then what's getting in our way? What are the big obstacles that getting in our way for New Yorkers to be able to connect once? And how do we get rid of those obstacles? So start with you, Zoe.
Think this might be the real trick or treat question. Yeah, it's a really good question. And, with TEFCA and the frameworks that came before it, like care equality, TEFCA in particular was Congress intended for it to be a voluntary network, right? It's actually in the law, it's in the legislation that this is voluntary, and that this shouldn't disrupt other, interoperability initiatives, right? So the goal of TEFCA is, not necessarily to replace all of those other exchange solutions, but rather to complement them and to maybe minimize some of the reduce some of the duplication that exists today, and maybe make things more efficient, right? We have a lot of exchange for use cases today, a lot of data flowing, like everybody has said, but it can be really unreliable, right? And really complex and really costly. And hopefully the vision of TEFCA is that there can be efficiencies built in to help streamline some of that exchange. But it truly is not meant to replace everything. I mean, I think as these guys mentioned, right, TEFCA doesn't allow for, or right now it doesn't support the capability for subscription-based alerts. So that's one thing. And, there are other things that sure, TEFCA has functionality for that could someday, help to reduce the need for some of these other connections, right? We have push-based messaging. It's being used at a much smaller scale than direct right now, but the functionality is there, and we are seeing uptake of that use case for, especially for public health, for submitting electronic case reports and electronic lab reports. But I think it's going to be a long time, and I don't think that, again, that's necessarily the goal, to completely eliminate, all of the other connections. I think the optionality piece, especially with government intervention, as things grow, I think we will see certain federal agencies provide more incentives for the organizations that they regulate to participate in exchange, and provide, business imperatives for those organizations to participate. And we'll also see expansion of use cases that are currently being done, using one-off connections. We'll see expansion of those use cases like healthcare operations and like public health and payment, and hopefully start to see those, more and more become required purposes. But there'll still be the need for other, local solutions, and local connections. And what I want to emphasize also is that if you're looking for, the one solution to rule them all and that one connection, then you should really thoughtfully think about which QHIN you plan to use. Right now, especially in the early days, there's a lot of optionality. We talked about the optional exchange purposes. And so QHINs don't necessarily have to offer to their participants and sub-participants. They have a lot of flexibility in the functionality that they offer to their participants and sub-participants. And so it may be that some QHINs are really only using TEFCA for certain exchange purposes, or certain transaction types. And so I think it could really vary, and it's really important to take into consideration your business needs, and what you want to see from your connection to TEFCA, and what you already have, good solutions that are working today for, and you don't need to be replaced by TEFCA.
Thank you. And
Well, I want to say yes, Virginia, we're going to, but I don't think the proliferation will stop. Sure, we'd like to have fewer pipes for the raw transport, if you will. I'm a TEFCA optimist. I think I'm very hopeful that working with your primary EHR vendor, that's your major on-ramp for a lot of interoperability. But you said SureScripts was the first network. They do a lot of value add that is not what other QHINs do necessarily. And Todd's described things that Healthix is doing, that is value add on top of the data. And I expect that to continue and maybe proliferate, and you'll end up needing to have relationships with all of those organizations and data use agreements and all of the things that we do today. Even if perhaps the transport gets easier. We haven't talked about fire yet. How do we get this far into the day and not talk about fire? So maybe transport gets easier, but I think there will be many other organizations you deal with on interoperability, not just interoperability, on value add on top of the data. And I think if Mickey Tripathi really were here, he'd say he wants those to proliferate. He wants more of those things to grow and innovation to thrive.
Right. So my analogy on this front is I've kind of been on a bridge trying to cross to the other side. Now the other side is that kind of the one connection you talk about from a customer perspective. So NYP has just one way to send the data up. But I really feel that HIEs have provided that bridge strategy on being the one connection in the past and currently in many places. Maybe the QHINs will take that over. Right now, HIEs are starting to feed into QHINs as well, up into TEFCA or the national exchanges like CommonWell and eHealth Exchange or Care Quality. But I really believe that there are kind of two customers that we're trying to serve, which kind of poses a challenge. We have public health, and then we have the provider payer community. And I think those are really different, call them market segments. And it's hard to serve public health without having complete data, which means maybe it's non-consented data from a patient perspective. Public health is very broad. Then you have the other world of the provider payer mix, which is, you want to give the individual patient more choice on how their data flows, but obviously you have the same challenges of bringing all that data together, right? That's the challenge. How do you get it all together so you can really serve your patient well, even when they think it may not be in their interest? As a clinician, you may think it is in their interest to know if they have a certain condition, and they're not telling you all their meds, whatever it is. So I think you just keep that in mind. There are two different market segments we're trying to serve. So I think getting down to one connection is really hard. That bridge keeps getting longer and longer as I walk across it. But anyway, it's a very long bridge. Go down to Florida, you'll see a very long bridge.
Just remember the amount of contracts, the amount of risk we take on, the amount we're paying, the amount of work we have to do. That's a lot. So if there's a way to just make the architecture more streamlined, that would be a fabulous thing.
The tough thing for us right now is, at least at Healthix, we're up against Epic, So I would say at Healthix, yes, we could be that one connection, but Epic is your main, those who use Epic, that's their main platform, or eClinicalWorks or Oracle. That is your big conduit for all your connections. So I think that's your challenges.
I'm going to annoy Todd by saying I don't feel like we're up against Epic. I'm a big fan of all of the interoperability they enable. So we want to be complementary, and I know there are those competitive dynamics at times, but I'm a big fan of what the EHRs are enabling clinicians to do.
And I'll just add, I think there's a role for everybody in TEFCA. So even if you have providers that are connecting through their EHR systems, they could still utilize their HIEs who may also be connected to TEFCA, and they don't have to be in the same QHIN, but you could still use your HIE to perform queries for certain exchange purposes. If your HIE is providing a service that your EHR is not providing, there is flexibility to leverage both of those systems.
So I'm a little worried about time.
If we have brevity and answers, a couple questions from the crowd would be awesome.
Okay. So I'm going to skip my last and let the audience harass them.
Great. My question is about actually consent. Paul Meyer, Smart Health Network, and maybe building on David's point earlier, maybe for you, Zoe, what's the view or vision for how TEFCA actually deals with individual consent? How do I, as an individual, express my desire or lack of desire to have information shared? And the related question then is, the whole point about interoperability is to actually inform care. A lot of what you need to know about me isn't sitting in EHR data. And so what's the vision also for how TEFCA or other interoperability frameworks actually eventually bring a fuller picture from social care, SDOH, other data actually into that, rather than just being a conduit for kind of traditional EHR data to other EHRs?
That's a great question. Two great questions, actually. And to the first one on consent, TEFCA is built on applicable law. And so it relies on the data holders to follow their own applicable law and the rules that they are required to abide by, depending on where they are, in order to exchange. And so as far as consent goes, if you're at a provider organization or an HIE that requires consent before release, and as we know that that's a major issue in New York, then that's the applicable law and that's the rule that you abide by. And there are mechanisms in TEFCA to be able to exchange that consent. So we have standards for exchanging it, and if it's not available, the data holder can ask for that consent to be provided. And then as far as the getting all of the data from across the continuum, again, I think that's really where the HIEs play such an integral part of this community, because I think they're the ones that are going to be able to provide those services and provide value and meaning, and aggregate that data and do other things to that data to actually make it meaningful.
In the back right of the room. We agree with that aim for sure, and we are making slow progress. Again, it takes time. We are getting the health-related social need screenings united with clinical data to some extent. We haven't used the word utility or health data utility yet, but I do think that we're trying to make the SHIN-NY function as something of a utility for the state as well. Utilities are governed in different ways, and we could go into that, but it's something I think that would be very valuable to the state, is to have that utility type function to combine data to enhance data.
Dr. Otem, the AI in Fetal Medicine Institute. I have a question regarding AI. What do you plan regarding the implementation of actionable AI? But I mean actionable AI, it's not medical publications and research, but tools that can be used in patients safely.
I do not. That's the quick answer. I'm hoping to feed data to other organizations that do that. I mean, AI models are voracious data consumers, right? And I hope that interoperability enables others to do much more with AI.
So at Healthix, we do have a project with AI. We're using Microsoft Copilot to summarize the data. And really, it's just the data that Healthix holds. So it doesn't go out to the internet. It's not connected to the internet. It's only connected to our data repository. And as a clinician, not verbally because it's PHI, but you can type in your question, summarize Todd's last 2 office visits or last encounter, et cetera. And it'll go and fetch and summarize. And that's just a tool to make the data more actionable to the clinician, to save them a little bit of time instead of going and looking under different folders. And, we've gone through the user interface many times to make it more user friendly, but we feel AI can be an additive tool on top of this to help find that data. So we'll be implementing that hopefully second quarter next year. But we're the first working with our vendor to do this in the US. So we're excited about it. And hopefully it doesn't hallucinate. So
just going to wrap up. Thank you to our panel here.
One more, maybe?
Oh, we have another question?
John,
Okay,
one more.
sorry.
Hi, I'm Matt Bishop, CEO of Open City Labs. We have an AI-powered care plan product. My question is about identity and especially the health equity challenges around accurately identifying patients. Half of Medicaid patients do not have a driver's license. And so while there's a lot of exciting opportunities around like the mobile driver's license standard and being able to kind of prove your identity when you with the scan, have you seeked out, this is maybe more for David more than anybody, partnerships with like the Department of Motor Vehicles or New York City that create their own city identity that could kind of improve that kind of data matching or person identification prospect, because obviously that's central before you even get to consent.
Certainly seeing from disparate sources as belonging to the same person is really central to interoperability. Of course, we use probabilistic matching, as I'm sure you know, and we do use referential data. Most HIEs are using referential data sources. It does get harder when you go from a health system to a regional HIE to a statewide, and then at a national HIE, it is harder.
Yeah.
I don't think maybe others will disagree. I don't think it's the problem it was 10 years ago. It's not like the thing that we're worried about. I think we do a decent job. I tried to work with the motor vehicles department in Maryland, and it was incredibly difficult.
I can imagine.
For what it's worth. I haven't tried in New York.
All right, let's give him a hand. You, Virginia, for moderating a great discussion. Interesting. So conflict, consternation, difficulty. We are moving towards figuring out how to address that, and some of it comes back to views of us, them, right? Everybody, here's the way we do it. Here's how things work. We have some new kids on the block here. The new kids on the block are the QHINs, and partly by being required and partly because of the value that they're going to bring. And it sort of reminds me a little bit of remember financial networks and ATMs? Well, that was just one use case. There was Cirrus and Nice, and I think Mac it was, right? And they fought, and it was hard, and you had a bank card, and it would work, but not at that bank. Eventually, that went away. So maybe in 15 or 20 years, we may get there. Our moderator for the next panel is Kevin McAvee. Amazing individual. He'll do his own bio as part of his presentation, setting the stage. So we'd like Kevin to come on up. But I will share that even though he'll introduce himself, I wanted to notice that his impressive set of colleges include 2 in upstate New York, Colgate and Cornell, very great institutions. So come on up, Kevin.
Better?
Better.
Okay. Eat this because I can't see you guys. I'm not tall enough. It's really nice to see you all. Good morning. It's a pleasure to be here on Halloween. I was gonna come dressed as a Yankees fan, but I missed it by missed the last costume by 1. I missed it just by 1. I love New York, and it's wonderful to be at this event. And I would actually just love to get a sense from all of you where you're coming from in New York. So if you're from if you're based in or work on Long Island, would you raise your hand? Okay. How about in the boroughs in New York City? Okay. How about upstate, which I think some folks down here consider anything above like a North White Plains. Okay. So we have a good spectrum here. How many of you working on the ground at a provider? Okay. Plans? vendors to the community. Really, really helpful. And it's also just great to know where we're all coming from, particularly if we're coming from out of state. And I think though that just exemplifies the types of gaps where we are hoping to fill in our environment on a daily basis. My name is Kevin McAvey. I'm a managing director at Manat Health. Health data is at least my professional life. From health information exchanges to APCDs, health data utilities to health data organizations, California to New York, Montana to North Carolina. I think about clinical data, claims data, vital statistics every single day. I'm proud to and privileged to have had the opportunity to support the establishment of the data exchange framework in California. Now working with David and nice to think about what the future holds for New York, as well as having the opportunity to set up some of our state health data organizations. I love New York, as Al mentioned. I grew up on Long Island, lived in central New York for 8 years. I live in Westchester now and work in New York City. Through all of those experiences, I benefited from our first class and excellent healthcare system, from the North Fork all the way to Buffalo, and how lucky we are. I'm also incredibly lucky on this Halloween to have these two who I'm coming home to later today. They're in our neighborhood. We get a tremendous number of trick-or-treaters, and I'm expecting over 1,200 after I leave our event. Where I wanted to I was thinking about like how to kick off this day, and I always like to kind of start off with a story that takes us out of sometimes our quite weedy conversations that we can get in. And so I've been reading a fair amount about history lately, and I thought one example that I just wanted to kind of put in the back of your minds before we get to our esteemed panel today is our American interstate highway system. When we first started out in the 1950s, 1940s, 1950s, we didn't have the benefit of being able to get from place to place easily. And we had to rely on really fragmented roads, patchwork of existing roads, mix of paved and unpaved roads, old bridges, and narrow passageways. And Eisenhower was tasked to do a current state assessment and really help set a vision for where we want to go from here. He looked and kind of pulled from his experience in World War II, really looking at what they had in Germany from centralized leadership to set the roads, the basic infrastructure of our system up to work well. And he worked with Congress to ultimately pass a grand plan, obligating $50 billion of federal highway funds over 10 years. That's around $650 billion today, to develop a vast system of interconnected highways across our country, which we now benefit from today. In making the case, he cited 4 things. He cited safety, 36,000 fatalities at that point per year. He cited the physical condition of the current infrastructure, the impact on cost to the economy, as well as the individuals. He cited the economic and demographic imperative, how we are as a growing country, how we are now as an aging country. Are we equipped to actually handle what's to come? And he cited national security. In that case, he was really thinking about and made the case, if a nuclear weapon were to threaten one of our major cities, how quickly could we get out? No, not quick enough. I say all this with the reflection that we just lost 1 million people in this country to a pandemic, which we were ill prepared to respond to. We're making progress. The interstate highway system, 48,000 miles in distance, was completed after 3 decades. Change and reform takes time. It also takes vision and leadership and a community willing to have the ambition to keep pressing. And I'm really I feel privileged to have the conversation today around how we continue to press in our ecosystem for better health information exchange. Is it going to be the answer to everything that we've been hoping for? No, it's not. I mean, but it is another step forward, and I'm really looking forward to talking with our QHINs today about how they actually help us to move forward. I had a few slides, but for the sake of time, to introduce the QHINs, and especially given that we've, I think, covered this ground, thanks to David and Zoe and Virginia, I'm going to tick through. But ultimately, QHINs are large health information networks that are volunteering to support as a backbone for network connectivity across our country to support TEFCA-based exchange. Each QHIN represents dozens or even hundreds of health systems, health information networks, federal care providers, public health agencies, payers, and health IT vendors. And in New York, it's a particularly interesting situation to think about the role of the QHIN. In our last panel, we started, I don't think it was actually stated, but I mean, we started talking about like nesting networks within networks within networks in the hope of ultimately getting to a complete picture. And now we have to also to face the challenge of within that nesting upon nesting upon nesting, it can result in a heck of a lot of information coming to us, and not all of it can be useful. And in fact, that volume of information can prove to be existentially challenging. So as we talk to our QHINs today, I would ask you to think about the questions that you have for them, and how does this all fit together in New York, where we already have a pretty mature and comprehensive, albeit regional, presently, HIE infrastructure. How do these national reforms, and specifically our QHINs, align with and address our health information gaps of our facilities and plans, many of whom in this room support? How do they address our patient privacy priorities, if at all? So I'm going to introduce our panelists today. But as a reminder, I believe we have 7 QHINs: eHealth Exchange, Epic Nexus, Health Gorilla, Kanza, MedAllies, CommonWell, Health Alliance, and No2 joined the pack in February 2024. And I'm looking at Zoe here for a gut check. Our candidate QHIN, SureScript, NextGen, US QHIN.
No.
Okay.
No.
You, okay. Who's
Clinical work students.
perfect? And then Oracle announced this week to apply to become a QHIN. I'm going to ask our QHINs to come up in this order to share for about 5 minutes their elevator pitch to all of you. But before I introduce them one at a time, I do want to provide a little bit of background about each of them. A. John Blair has been Chief Executive Officer at MedAllies since its inception in 2001. Dr. Blair is a healthcare and technology executive with broad experience across the healthcare industry, including clinical practice, hospital planning, and governance, like a heck of a lot of experience. Prior to establishing MedAllies, Dr. Blair worked as a general surgeon for 20 years before becoming president of the Taconic Independent Practice Association, a network of over 5,000 physician members. Through Dr. Blair's leadership, TIPA was at the national forefront of transforming healthcare delivery by implementing and ensuring the adoption of the meaningful use of health IT and pay-for-performance incentives. Paul Wilder, sitting up in the back right now, who I think many of us know well, Executive Director, CommonWell Health Alliance. Paul is leading the organization into a new chapter, empowering clinicians, practitioners, individuals nationwide with interoperability services. For CommonWell, Paul was Vice President of Strategy and Business Development for Philips Interoperability Solutions. He also spent nearly a decade at NICE as Chief Information Officer, VP of Product Management, and Program Director for the Regional Extension Center. He knows New York well. Nahit Bajaj, a solutions specialist at Epic. Nahit is an interoperability lead at Epic, helping customers support care everywhere Epic's interoperability platform for patient record exchange. Additionally, within the industry, he serves on Care Quality's Advisory Council and is on the Sequoia International Interoperability Matters Steering Committee. And then finally, Steve Yaskin, last but not least, CEO of Health Gorilla. Yaskin co-founded Health Gorilla in 2014 and has led the company through 3 strategic funding rounds, including a $50 million Series C round in March 2022. Before Health Gorilla, he was CTO for Elite Medical Center, a provider organization specializing in primary care and geriatrics that served more than 50,000 active primary care and chronic disease management patients. He has a long-standing history in the technology and digital health space and closes out our four-person panel for today. I'm going to ask John to come up and provide a few words on MedAllies, 5 minutes. And for each person, we're asking if they could provide an overview of their QHIN, including distinct services and membership, and a real example, if possible, of how someone's onboarded and benefited from the service. John.
Can everybody hear me? Okay. Paul, did you ever think we would be called the new kids on the block? I think that's what we were, right?
Some question.
Yeah. All right. I don't think I have a an elevator pitch, and I think I would be loath to try to stand up in front of my competitors and pick them apart and fan our flames. But I'll tell you a little bit about my background. A lot of what these QHINs do are the same as we've heard, because by design, the technology in the middle is essentially identical. We go through a very rigorous process on the conformance testing to become a QHIN. Those 2 candidates right now are probably suffering through it right now for on their way to designation. But anyway, I just want to give a little bit of background about myself. You mentioned Taconic IPA, so I just have to bring that up because it just was north of here where this all really started. And then I don't know if anybody remembers Think Rio. That was part of what I put together with Lori Evans in the day. And then I'll get to MedAllies and a couple of things about MedAllies that I think are important to understand. And it's not that the other QHINs don't do that. Some probably do and some don't. But for me, started out in academic medicine, came up to the Hudson Valley and was in a surgical group, ultimately became the president of Taconic IPA up in the Hudson Valley, 5,000 doctors. And from that, with our frustration on coordination of care and improving care, we started a little company, or I started a little company called MedAllies that was strictly for the purpose of getting coordination of care amongst the doctors as they came up on electronic health records. And we heard about comments about HEAL 1, 2, whatever. I think Rio was the recipient of probably maybe all but one of the HEAL grants. So that was kind of our initial venture capital, I guess, for the region to build out all the things we did. But ultimately, MedAllies went through electronic health record implementation, several thousand providers in the region. So we know that well. We were part of NCQA's patient-centered medical home and the development of that. And at one time had the highest level of, or highest number of level 3 patient-centered medical homes in the country. So we really understand the workflow and the importance of all of that. At the end of the day, at least for providers, data can flow all over, but if it's not usable and well built into the workflow, it's irrelevant and not used. So we understand that. And I do think that brings a little bit of uniqueness because we were started with clinicians that came from multiple care settings. And today, even though all we do is move the data, we understand the importance at the end of it for the users. Anyway, MedAllies did all that. We ultimately got focused on interoperability. We were very involved in the direct project as it came about, and were early on a national direct network. We still do direct secure messaging have probably close to 150,000 providers on our direct network. So we understand the business of running a national network. And Paul's probably tired of hearing me say this, but technology is only a piece of this. And to do this well, you need, I believe, close to an equal investment in the professional services and the operational side of this around onboarding, around support, around working with these vendors, how they implement this so they build this properly into their workflow and usability. So MedAllies, if it distinguishes itself in any way, is that because we have never let that go. And that has carried on as we became a care quality implementer. We did that in the lead up of becoming a designated QHIN. We were one of the original. It's been a little bit under a year we've been doing this. We heard from Zoe and others how difficult this is. We're really doing something that's trying to coalesce many of these national networks. One on-ramp that was that people are looking for, that was mentioned, one connection to everything. I don't know if I'll see that in my lifetime, but I do think you will see a coalescing of many of these networks to get you to one on-ramp for one type of network. I don't think HIEs will go away. I think they're part of this. I think, again, they'll probably move more and more from just connectivity and data and moving data to what we've heard about with analytics and all of those other pieces with data and the utility. So MedAllies as a QHIN is doing what all the other QHINs do. We are moving data from its site of origin to the requester. So we all do that. There's a different flavor. Some hold that in the middle and are able to do a lot more with the data in terms of longitudinal records, analytics and stuff, kind of more like national HIE. Others are purely a conduit. We're a little bit of both. We are strictly a conduit. However, we have that capacity on the edge for different types of stakeholder groups to do things with the data, dedupe it, clean it up, do analytics on it, do reporting for it. And that more plays to payers and other entities that we're contracting with. And then others just want the data from its site of origin brought to it to bring that together, that organization themselves. So it varies with provider or with different stakeholder groups. We try to meet both of those. You asked about some of our, I've got 1 minute now. Okay, you asked about some of, we are dealing with treatment. We have EHR vendors and have brought on a couple of those products in the last year. We have individual access service, consumer facing platforms. There's a company called Selfie that went live on our care quality network that's going live on our QHIN. And then we also have payer facing companies. Some may be familiar with DataVant, recent company that's contracted with us that will be taking the data and they're a request of information company. So, we have all of those types of companies. And just one thing you asked about what we do in terms of an organization, how they may onboard or something. I'll take Veradigm EHR is connected to us. And what we've done with them is through a gateway built into their 2024 version. So that's going to be fully, they redo their version every year. So by the end of this year, we will be connected to those 1,500 practices and 16,000 providers. So they already have our network, already have it. And we've gone through some automation tools so that if a provider organization decides they want to be activated, they flip on what's necessary for the functionality of the software, bring that group on in 2 days. So we can bring those on very quickly. And that's just an example of what we've done. Thank you.
Terrific. Thank you so much.
You want us to sit up here when we're done or?
No, you can go through.
Okay.
Paul, where you at?
Here.
Okay.
No, maybe, kid not.
Yeah, kidding.
He got a clip-on thing. I think that's unfair. It's all good. Good. Are we still morning? I'm so confused. I was in Australia last week. I don't know what time zone we're in. They actually don't switch daylight saving at the same time either. So like things go really wacky. Your calendar goes berserk. It was impossible to keep up meetings. Good morning. Paul Wilder. I'm with CommonWell now. As was mentioned earlier, fairly long history in New York State doing good, bad, or indifferent things relative to Interop. Used to run, well, actually my staff and myself designed the shiny architecture we have today relative to the QEs connecting. Actually very similar architecture to CommonWell, right? It is a gateway of gateway approaches with a master index above it to help coordinate what you can see across the various entities. So if you look in New York, you have Rochester. If they are looking for data, they don't say, I want data from Buffalo. They say, hey, nice. Who else has this same patient somewhere in New York? And they say, well, Buffalo and Healthix has something too. Oh, okay, I'll go get data from those two and suck it in and do what I need to do, normalize it, health data utility stuff, all the stuff we're going to do. You know, the real power here is in knowing where the data is, right? So we talk about trust and community at scale at CommonWell. And to give you an idea of scale, we are structured a little differently than the way HIEs are traditionally structured, that our primary members are vendors. So our primary members are going to be health information technology vendors, particularly electronic health record vendors. So Athena, eClinicalWorks, Oracle/Cerner, whatever history lesson you want to go from there. And that balloons out pretty quick. So we only have, I think it's 42 active connections to our network, but we're connected to gateways. So that leads up to 37,000 clinical sites, right? And actually, we think that number is low because Oracle is underreporting the facilities underneath their connections. So some of those are IDNs that fan out even bigger. So it's a lot of scale really fast. It's about 500 million documents a month flying around, both inside our network and then through other frameworks we can include. So when we think of TEFCA and what we're doing, TEFCA was a natural extension of what we do, just as connecting to care quality was, right? So care quality, which, you know, Epic is one of the founding members, I think he's here somewhere, right? Yeah, there he is a framework of connections, and we built a bridge over to there. And now we're building a framework for connections under the TEFCA paradigm. Why the switch? It's a great question. We'll talk about that a little bit probably in the panel, but I'll finish the thing about CommonWell. So we are really designed for doing things at scale. We actually do have HIE participants, interestingly, one from New York even. So, you know, we're proud to have that. Our architecture is designed around a record location system. Now, what's record location? Read the words. Where are the records located, right? They're located here, here, and here. That does not mean I know what's in those records. So part of the trust framework here, and that's the second part of our network, is a contractual trust framework that, you know, providers will provide data. They will also have the right then to get data. And this analogy doesn't work all over the country. It tends to work in the Northeast. Most people here have heard of potlucks, right? You know, if you think about potluck, it's often attached to like a charity event or something, right? You got to buy a plate, but you also got to bring an entree or an appetizer to share with others there. And so when you think of Interop, the reciprocity, the data sharing, a lot of it has to do with that. I agree, I will share my data. In exchange, I also get data. So while they pay to be part of CommonWell to get the base functionality established, the real cost, the real currency is the data going back and forth. And it's equalized by I can get data and I give data. So just like a potluck, I have to buy the plate to support the charity, but I still got to bring the entree that everybody's going to take from me. Right. So it's, you know, it does cost money to run this stuff. We're a nonprofit, just to make that clear. We're actually a 501c6, which a lot of people don't know. So we're a trade association. And if you think about what I said, my structure is our primary members are vendors. So we're a trade association. We represent what trade and the marketplace needs. And when we formed, this is 2013, what was needed was what we thought, or at least our members thought, was for the members to get out of the way of thinking they will control Interop and the data exchange that happens after that. The belief was no vendor is a single vendor solution, a single solution for everything. We needed to connect together, and that we needed a coordinating traffic cop, both contractually, so that's the trust framework, and the technology of the record locator system and the MPI. But it is, to be very clear, and this is very similar to what John just said, we're one of the QHINs that doesn't store any data, right? Actually, that's not true. We store
identifiable data, right? You asked me where Paul is, I tell you where Paul is, so I must know who Paul is in the first place, right? So we have personal identifiable information. We don't store any clinical data. You could ask me, I guess, what are the percentage of male versus female patients in the United States? I probably know that. If you ask me how many diabetics, I don't have a clue. And I'm not going to go purge and pull 250 million patients. Like we have 253 million persons in our index right now. That balloons out to about 950 million individual patient records. We're not going to pull all those to get that answer. So as we advance, you look at TEFCA, you look at new use cases. We're very excited with the new use cases. I will say some of them don't really line up as well in a query-based exchange network. We have some work to do. Particularly like you look at public health, which tends to be a reporting thing, not a query thing. But you don't find out how much malaria is popping up in the country by querying all 850 million of my records every hour, right? That's not the way you do that. So, there's more to do than just what TEFCA starts out with. There is a push technology embedded, and I guess we'll talk a little about that as we go. Thank you.
Thank you. And next we'll hear from Nahid from Epic. Come on up.
Hey folks, I'm probably the newest kid on the block here, so happy to be here. I'm here to talk about Epic Nexus. I think most of the folks here know who Epic is. Epic is a EHR vendor. We help serve our community across the nation. And our Nexus is our QHIN product that's designed specifically for users using Epic. It's designed to help streamline interoperability, but really focus on the end user workflows. So the user has no recollection or even understanding that they're exchanging through TEFCA versus any other data exchange that'd be happening. So we're really focused on helping our physicians be able to benefit from getting external data for patients, treating the patients well, without realizing what's happening in the back end. We have heard a lot here today about TEFCA adoption and what it means and where we're going and the train that's moving. At Epic, we have bias towards action. When we are committing to certain things and we're saying certain things, we want to actually be able to produce results. And one of the things that we've been sharing publicly, and I'm going to reiterate and share that, is our goal and our hope is to get all of our Epic community live on TEFCA end of next year. And we do that because, so we're sharing that because we really do find value in TEFCA that supersedes what exists today in the current interoperability frameworks. I'll talk more about that afterwards, but we do see the benefit in having ASTP oversight, the sponsorship in TEFCA, the comfort it provides our healthcare organizations, compliance teams to know that the data that's being exchanged is being done for the appropriate reasons. I want to share this cool fact with everyone. So today we have 79 healthcare organizations across the country live on TEFCA, live. That comprise of 736 hospitals and 9,888 clinics. And on top of that, we have 105 other organizations that have already reviewed and signed on to the agreement, are in the process of implementing turning on TEFCA. So we're already making a lot of really good, meaningful progress here. 10 New York organizations have actually pledged to join TEFCA, and we had some preliminary conversations with them, and they understand what it means. So again, I think I want to reiterate and share, TEFCA is real. It's happening already today. I think we kind of hear a lot about when TEFCA was first explained is the TEFCA's goal is to help close the gap in care that exists today. Even in treatment, I think a lot of times people are thinking about the other use cases, which is really important, but in treatment, there were, I think, estimated around 20 to 30% of hospitals that weren't connected. So meaning if a patient was seen at that hospital that maybe you know about, you're still not able to pull data today through the current interoperability frameworks. And the goal for TEFCA is to help close those gaps in care, to get everyone on board. We were one of the first group of QHINs to connect to TEFCA, and we actually were part of that first exchange that happened with TEFCA, so we're really excited about that. But we wanted to dive into that little bit of gaps in care metric and see what does that actually mean. I'm a numbers person, I think. I look for math to back up the conjectures I make. And so we did some assessment and found that today we have had our Epic organizations through Epic Nexus have exchanged over 2 million patient records through TEFCA that they wouldn't have gotten in any other interoperability framework today. So these are net new connections with hospitals and clinics for treatment, that we're able to close that gap in care because these organizations join TEFCA, that again is value add for them. We think this is powerful. We think obviously in order for TEFCA to succeed and be successful, everyone needs to join. And so hence we keep reiterating the importance of joining and doing it appropriately. And we're hopeful that others, not only in Epic, but other vendors will also start to onboard their clinics quickly. I was going to give a quick example of what that onboarding process looks like as part of the overview. And I think it's interesting because I was just talking to an organization that onboarded just last week. I think the longest part of an onboarding process, if you're interested in joining TEFCA, is actually the QHIN participation agreement. That requires a lot of the review to make sure not only do you understand what it means to join TEFCA for treatment and other purpose of uses, but also a lot of times organizations that have an EHR instance extend that EHR instance to other subgroups. And so they're likely going to be your sub-participants. So you need to ensure that your sub-participants knows the relevant terms and understand and can comply to it. And that process taking the longest is a good thing. It being the right thing to do, everyone's aware of what it means to join TEFCA, what it requires, is foundational to anything else that you do within the framework. The actual technical implementation takes hours. We had a group who actually went live on TEFCA a week after they were done signing their agreement through their entire change control processes, having multiple hospitals, multiple organizations go live. And they actually also, as part of their TEFCA onboarding, went live on electronic case reporting that we talked about, essentially reporting to public health agencies that they hadn't done previously. So again, joining TEFCA to them and many others was a net new added benefit that they didn't have today. So again, excited to talk about a lot of other topics here, but wanted to make sure you all knew about Epic and Epic Nexus, our mission, our vision, and ensure that you know what we hope to accomplish through TEFCA. Thanks.
Okay, last but not least, where's Steve? Okay, here we are. Really nice to see you. And then, so after this, I'm going to ask all of our panelists to come back up, sit over here really closely. And then I'm going to ask 3 or 4 questions, and then I'm going to open it up to you guys for the questions that you have for our panelists today.
Good, thanks.
Yep.
I'm Steve Yaskin, CEO, co-founder of Health Gorilla. I'm also one of the new kids on the block, and I would say very honored to be in a company with John, Paul, and others that spent decades in the field. So we decided to bring kind of Silicon Valley mentality and technology advances into the fray. I still remember a couple of years ago, first of all, about myself, I grew up in New York, and I moved to Silicon Valley, gosh, about 20 years ago, where they tried to remove Brooklyn out of me unsuccessfully. They failed. They kind of failed at that. So I brought Brooklyn to Silicon Valley, and I'm back here to try and make change into interoperability space. My heart is in New York. Sorry, Yankees fan. I'm kind of torn because I live in California, but also major fan of Yankees. So I was watching the game on a plane yesterday, had my iPad, and had like 10 people gathered around me on a plane watching the game because I had Wi-Fi. For some reason, nobody else had. Health Gorilla started a couple of years ago, and I still remember when I had this original vision, how we can bring technology advances into the realm of interoperability. I had a lunch with Marianne from Sequoia, and I presented my case, how we could bring technology and innovation and what we can focus on. And she said, well, Steve, this is all great, but you need governance, right? You need adult supervision into that. So we spent the next couple of years building an executive teams comprised with some of the industry veterans from Interop field that actually created governance. And somebody said, TEFCA without T is just TEFCA. I actually really like that field, but I think governance, technology without governance in this field is also very dangerous, as we've all watched some of the recent events, how trust got eroded, and we're trying to build it back. right now using the QHIN designation. Health Gorilla was also one of the first QHINs that actually live exchanged data in December of last year with several other QHIN participants. We were very proud to be there, but we also spent a lot of time working with the states. We've done a lot of work in Puerto Rico with all the challenges that Puerto Rico presents. We got disrupted several times by various hurricanes and other events happening in Puerto Rico, especially the last one kind of put a big reset for the whole island, but we're still working there, still very active. And we did the same in California. So California has a very similar program to TEFCA called DXF, Data Exchange Framework. And, you know, California likes to do things in their own way. They take federal regulations and Californize them, for lack of a better term. New York is kind of similar. They have very, you know, unique state laws here. Very interesting environment, but Health Gorilla is the only QHIN that qualified as a QHIN on the federal level and also qualified as a QHIO in California. And we find ourselves in a very interesting mix. First of all, we're Silicon Valley company, so I have a board of operators, and I have to get my marching orders from SOPs from RCE. So it's kind of weird situation, but we're making it work somehow. Governance, technology under governance, what does it mean? Health Gorilla is focusing on several key components. Universal adapter, record locator service. We spent years building our RLS. Data normalization engine. We speak 120 different healthcare languages from CCDA, HL7, all kinds of transactions, mapping this out, converting into FHIR. We support several models. We're pass-through, we federated, but we also aggregate data for analytical purposes. We're very open about it. So we do have a thin data lake layer that we use for analytics and performance and other secondary data usages. Health Gorilla serves digital health primarily. Vendors, Health Gorilla serves ACOs. We also have payer contracts nationally. Health Gorilla, by the way, started with the labs. We build our own labs diagnostic network, which we are happily sharing with the rest of the QHIN participants and care quality and CommonWell networks. And recently we started working with the EHRs. Anybody whose name is not 4 letters starting with E. We're working with pretty large acute EMRs like Meditech recently switched, adopted Health Gorilla QHIN, ResMed, Matrix Care. So we focus a lot on home health, Canvas, Dr. Corona, and many other ambulatory EHRs as well. As a QHIN, I think we invest a lot in our compliance governance, but also being able to support all 6 permitted purposes as we get SOPs. We participate in a lot of feedback we supply. And our commitment to the QHIN market, to TEFCA in general, is that we will be kind of on the bleeding edge of bringing technology to empower each of the permitted purposes as they get adopted. Health Gorilla is a neutral player, which kind of sets us apart a little bit. So we have our own niche. We are not in the EHR. We didn't come out from EHR. We're not in HAE, but we are purpose-driven QHIN. We were created as QHIN, and that allows us to be a lot faster in development cycles. That's it. Thank you very much.
Okay, so I think we have time, maybe a couple of questions, and then we'll go to the audience. Okay. So it's so great to see you guys, like all up here. And Paul, I'm going to ask you a question that you asked the audience at Civitas a couple of weeks ago. You asked, everyone should ask, how does a QHIN help me? And I think that's a question this audience would be really interested in hearing an answer to. And so I'd love, if you want to kick us off and then we can go down the line, I'd love a thought from everyone. How does a QHIN help me?
I wish I knew. Well, actually, it depends, right? So when we talked about, John actually mentioned, and I'll steal from a little bit, that there's some equalization of the QHINs to some extent, but that's really at the edge, right? So if you have a phone, what you want to be able to do is call any phone number, right? You don't want to have to say, is this person on AT&T or are they on Verizon? Do I have a bridge across from that? Like, you know, for the elder statesmen of the room, including myself, when it comes to IT, you know, there was a day where we had like things like Prodigy and CompuServe, and we had these, you know, siloed email systems, and they did not connect. And you could send your friends a CompuServe message, but you better have Prodigy too if they're on it. And at some point, they bridged. And the QHINs are designed to help make that bridge work, right? How they work on the inside could change a lot. Right, some are going to be fan-in, some are going to have an RLS that's, yeah, it's precise. They're going to have different services, but at the edge, the technology is going to be the same. Very similar, by the way, to, and of course you use the analogy, so I'll amplify it to the highway system. I got news for you. New Jersey, I live in New Jersey. You show a Georgia person our jug handle thing, and they think we're absolutely bonkers, right? Like they're like, I don't. We're like, well, this is how you make more efficient right-hand turns, and we'll swear by it. But the freeway system is consistent, right? The signs are on the right, right? The green signs are there. Sometimes they're above, but they can't be on the divide on the left, right? There's certain things that have to be consistent for us to be able to have a system that connects things together. And the QHINs have a set of protocols, standards, and trust requirements that allow us to connect to each other. And then you have the stuff that goes on the inside. So when it comes to CommonWell, it's almost more of a question to our EHR partners, right? We believe that the workflow of Interop needs to be as embedded as possible in the workflow, the productivity tool you use all day, right? The equivalent I give, my productivity tool, but whether good, bad, or indifferent, is Outlook. You know, it's email. It's most of my time is spent there. If you pulled the calendar system of Outlook or Office 365 or pulled it out of Gmail and disconnected it from email, I would cry. Right? Because it's so much of the time is spent with meeting adjudication and invites and forwards, things with dealing with people and managing people and the content that goes around that. It's not just an email system. So you think about your EHR, the same thing. It's got practice management, it's got clinicals, it's got all this stuff. Interop being outside of that doesn't fit our DNA. Now, HIEs are different. HIEs are often just slightly adjunct. They might have OAuth, you know, credential flow to be able to go from in context from an EHR to out. But our primary member is going to be something that's embedded the technology. So we don't produce as much normalization stuff that a Health Gorilla does or the like. We're a little bit more of a fire hose because we expect the EHR to normalize it the way their data standards work once they get the data embedded to their side. So it's a question many times to the individual participant, Oracle, eClinicalWorks, et cetera, on our side of what do I get when I connect this Interop stuff? And right now, that is a debate, right? Sometimes it's too much data. I'll stop there because I can go on for about 42 minutes if you want.
Steve, John, anything to add?
Well, yeah, I mean, I think you need to call out which stakeholder group you're talking about because it's different. I mean, we talk about, you know, holding data in the middle versus a conduit. I mean, we didn't do the in the middle because 2 or 3 of our very large potential customers said, you do that, we're not going to do this. So that just made the decision for us out of the gate. So you have some of the customers that don't want that at all, that don't want the original data coming to them as widely as you can bring it in. And that gets into your record locator service piece and who's going to be able to get the most back for you. That's one thing. But then you go to a clinical, an EHR vendor and a clinician who says, well, you know, 10 CCDs, what am I going to do with that? You know, that's overwhelming. So we've built the capability of our platform to do some level of deduplication, normalization, and create a summary view from what comes back for those clinical people. If you look at, you know, the health plan facing thing, you've got to even go further than that with it. So again, it depends on the customer you're catering to and how broad you want to go to get to those different customers. If you try to do everything for everybody, you can't do it. So, you know, we've got 3 or 4 categories that we're catering to, and, you know, so that's That is.
I can go next. I think it's harder for us, right? Because we're not essentially competing in the same marketplace from QHIN valuation. I think for us, what we focus on is recognizing that it is intimidating and complex when we talk to our healthcare organizations about joining TEFCA. They see the SOPs, they see what's all on the website. And our role as a QHIN becomes simplifying it for them, helping them understand what it actually means to connect, helping create tools to help them understand what are their physical locations that they should help enter into the directory as part of the TEFCA requirements. And so as a QHIN, we become a conduit for them, the relationship to help them get on in the interoperability on-ramp. And I think that's what we see as our number one priority. And then number two, I think once you're live, a lot of times organizations tell us it's hard to get the help I need because I'm connected, but I'm not able to see the chart from this other hospital that the patient went to that's down the street. And I think our role, because we understand the EHR well, we understand how the data is displayed, we understand the configuration, we're able to help better serve and support our users by knowing how the data comes in and how the data flows out, and also what we expect to see done in the EHR. So really focus on the user experience.
Steve, anything to add?
Yeah, I want to echo that a little bit what Nikhil said. It's in a lot of these cases, we do a lot of work collectively as QHINs. Don't mind the man behind the curtain kind of thing, right? We focus a lot on data cleaning, data quality. MPI took us 5 years to build meaningful MPI that could stand up to what other QHINs are offering on the market there. But I similar to John, I built one of the largest IPAs, primary care, internal medicine in Bay Area. And at the end of the day, when I talk to those doctors sitting in front of the computer, at the end of the day, they do not care about I know this. All they care is what they're looking at on right there on the screen. And from previous experiences, especially in the primary care, it's kind of a front French in the war. All they care about, can I see that record in 30 seconds that I have? The patient is coming in, I've never seen that patient before. So to me, UX was one of the major differentiators is how we build the QHINs, which culminates in a screen, in the real estate. And of course, this is where you start having all those challenges because physicians, while they enjoy easier workflows, they want to be in one system, and that's always an EHR, and it's always a system of the record. So to me, that QHIN opened up that path to collaborate with the EHRs, with digital health vendors, with bespoke EHRs. There are a lot of value-based care providers now doing embed ourselves into those workflow processes, but also surface the data in a meaningful way to providers at the end of the day so they can, instead of seeing 5,000 documents, which is what previous networks used to do, and everybody kind of got used to that, see a comprehensive and actionable view of that patient in 30 seconds. That's all that we got.
You mentioned like reconciling patient identities, like a major role. And this is actually a question from someone out there in the interwebs who's we have, I think, twice the size of the audience out there listening to us today, which is tremendous. Receiving and reconciling patient identities across the nation must be daunting. How do you approach that and approach it well? I'm going to open this to anyone who wants to take this question. Okay.
Well, first of all, there was a question asked in the earlier panel as well about kind of the DMV and the driver's license. And we often do the perfection enemy of the good problem pops up all the time, right? There's a significant amount of stuff that's actually relatively easy to match as long as people are paying attention, right? And I think there was years where we weren't paying attention because we didn't care about Interop. You go back 15 years ago, thinking about the one of the lowest paid people in the hospital, and I'm sorry if I'm offending anybody, is that front desk registrar. That person right there is in charge of a significant amount of your interoperability capabilities, right? They type that in wrong, it's over, right? If they don't check the ID and see that doesn't match the insurance ID, we have fraud problems, right? There's a lot of stuff that goes on right at that desk. And we forget about that downstream. One of the things that we did that CommonWell does, this is a difference across the QHINs, and I'm not saying good, bad, or indifferent. We actually started out with no automated matching whatsoever for patient identity. What happened was inside of the workflows, we're talking about in the EHR, we had APIs that called into the MPI, into the master patient index or master person index, and said, give me suggestions on people that might be the same person sitting in front of me right now. And across the country, people were adjudicating those, that is the same person, because I can interrogate. I can kind of say, where'd you live other than New York? I lived in Illinois. What city? Evanston. Main Street? Yep, that's you, right? And so they would confirm things. Now we've moved to more automation. We do have MPIs that do normal matching stuff, but 80% of our links up until basically beginning of this year were based upon manual links, and that still led to 350 million matched records. So you do have to think about now, in an HIE sense, it's different. You tend to have staff at the HIE that do this. So you start out with an MPI with probabilistic matching, which David mentioned. You then put on referential matching, and then you have another queue of X number of people sit there looking at these near matches and deciding what to do. We just broadened that out as part of our trust framework of, it's not just trust of I give you data, you give data, but we trust each other to help make the MPI work better over time.
Any other quick additions?
That was a long addition.
I'll just add a quick addition. I think patient matching is obviously very, very critical and important, but when we talk to our organizations, they tell us that the patient medical record goes well beyond what's in the wall of work or what they're seeing at the clinic. And the external data is so much part of the patient's treatment. And when that data is wrong, meaning when you have the wrong patient record or listed in the current patient's record through external means, it can have very damaging impact. And so it is concerning, right? It's concerns to make sure that identity matching gets done well. So you're actually matching patients, but done it with the right patient at the right time. And so what we've done to help with that in the past and continue to do is we worked a lot of stakeholders in the past and have made some specific criteria to what we think qualifies as good standards for patient matching algorithm. And we recognize that the patient matching algorithm isn't really just an Epic problem. It has to work across the board in the industry. And so as our work with Sequoia and Care Quality, we actually published our standards and guidelines for other vendors to know and recognize. So they could essentially either benefit or adjust their own algorithms based on our findings. But yeah, we think it's really important to get done right, but can be very damaging if done wrong.
Yeah.
30 seconds edition. We shared the same concerns, the same visions, and our response to MPI, I mean, if you think about it for a second, HEs have really been doing that for decades at the local level. And as new kids on the block, we had to get really fast to the same level of quality on MPI, but do it nationally. So the volumes and the scales are a lot broader, and the cost of the mistakes, because sometimes we are not presented for manual verification, like CommonWell has that huge advantage. The cost of a mistake is enormous here. So we had to absolutely make sure it's bulletproof. And the answer to Health Gorilla's MPI, several years of development, was just to bring more external referential data. We also use probabilistic matching. We do not use AI for that at all, zero. Until such time that it makes sense to do so. But we do bring tons of referential data from credit bureaus, from experience, from many other external data sources to enrich, hydrate the data was the term David used, I think. I really use that term all the time. And the more data you have, the better criteria for the algorithm that you set and share with others, it becomes more precise.
Yeah, so John, I'm going to come to you next.
I just want to say one.
Yeah.
I mean, not all of us. Not all of us have probably invested as much as some, but I think this group here has put a lot into our EMPI, and we've invested a tremendous amount into that. Paul's actually looked a little under the hood at ours, but the short of a bake-off, I don't know how in the world, other than us talking about it, you're really going to know. And I don't know how we're going to get a bake-off to see who can bring in the most records. But anyway, I think the short answer is there's been a lot put into these EMPIs.
Yeah.
Anyway.
So I always rely upon you to ground us in the reality of like what's going on. We've talked a lot about today, like the good things about QHINs, like how we're starting to fill gaps with this, with TEFCA and its implementation across the country. Talk to us a little bit about the realities of implementation, things that folks will see. You mentioned duplicate records. Like, how can those be mitigated or avoided? How can we make sure that we're integrating this like QHINs into our clinical data flows, into our decision making in a way that makes a difference? And then I'm going to turn to all of you for a couple of questions from the audience before we go to lunch.
Yeah, I mean, a lot of that's going to fall to, I mean, at least for the clinicians, is going to fall to the EHRs. I mean, we can get them the data, but they're going to have to do something with it to make it more improve upon it. Now, there is a project out of Sequoia, data usability project that's been going on for several years. I think they're putting out their second version for their implementation guide, and then they have a subsequent thing called Taking Roots, which is actually implementing it. Maybe everybody here is part of that. I don't know. We are involved in that, in both the usability and the Taking Roots group, and have built that. I talked about, again, we don't hold the data in the middle, but to the degree that a participant wants us to do something with it, we have that ability at the edge to standardize it, dedupe it and everything. And we are following to the T and have implemented that data usability IG. So, I mean, that's one thing that we've done about that to improve it. I will say this, because Zoe brought it up later or earlier, and we've all been suffering through this for the last last month, I think. But one of the problems with these national networks and the trust has been, when you're bringing on or different potentially bad actors that are doing things or saying they're doing things that they're not. And there's been so I think there's going to be much less risk of that with TEFCA, because that would be a problem, wouldn't it? If you're giving up your data providers, the data sources, and it was going somewhere that was not intended. So there's been a ton of work to improve that. Anyway.
Perfect. Final comment, and we're to go for questions.
Really quick on the data usability. Totally agree with John here. We're a big proponent of data usability work from Sequoia and have done the Taking Root action. I'll say this, that was one of the things that our organizations actually were worried about. They recognized when they're joining TEFCA that a lot of their trading partners are already on other networks. And they said, am I now going to be retrieving data from Care Quality, eHealth Exchange, and TEFCA from the same participant? And am I going to see that 3 different times? And we've been lucky so far. We're hopeful that this trend continues, that organizations who have onboarded these entries in multiple networks have used a consistent identifier. So we can be very intelligent when we're requesting data to say, if we're already requesting data through TEFCA, maybe not also request that same data through Care Quality, eHealth Exchange, and other framework. And I think that consistent identifiers can be a really good source of benefit from organizations to streamline as groups onboard. Additionally, we have invested a lot in our deduplication logic, just like everyone else has, but recognize that that continues to be a challenge for the industry as a whole.
Terrific. So may I grab Mike? I think you would just raise a really important point about bad actors and the importance of consent. I think David started talking about the importance of state rules, regulations, in protecting consent earlier. That could be a whole session.
I just want to pick up on that last question around EMPI. Everybody's got their own EMPI. There are 6, 7 QHINs. They all have them. SureScripts has one. Cigna. Everybody's got an EMPI, but nobody knows each other's EMPI. So within sort of a QHIN to QHIN, the whole point is exchanging data between QHIN. You've done work within your networks or organizations have an EMPI, but the whole point is cross-network. So what's a model for kind of cross-network identity resolution, EMPI to EMPI?
Oh, I have to turn it on. Yeah. Technology. Just before I forget, just one thing. I'm going to answer that. One thing I want to add, the last thing. Please, please, please. I'll say I won't say the remaining 22 pleases. I was going to add. Check the output of your own data. One of the biggest problems we see in Interop is people have no idea what garbage they're spewing out because they only care what they're getting in. So before some other partner yells at you, find out if you have a normalized data set and whether you're being complete or not. It's embarrassing when you find out you just didn't pay attention to the paperwork that said which dials and switches to turn on. And like, oh, all I had to do is this and everything works fine, right? So just that. It is a very, very interesting problem right now, right? So in TEFCA, even more interesting, it doesn't actually specify you need an MPI. MPI is a voluntary thing inside a QHIN to decide if it's necessary for the way it coordinates what it does inside. You are allowed to do things like internal fan out, where I get a request for where's Paul, and I broadcast it to my entire network, wait for a response, and return back. And if you think about that, that amplifies that problem, because not only am I looking at, I could tell med allies, and in fact, in care quality, we did this. We had an exercise where we said, what's everybody's matching logic? We just gave everybody our spec and so here's what we do, right? So if something's not matching, you might want to look here and see what's wrong. Now, what's interesting about that though, is you don't know when you make a request what the other side data actually is. So you can see that I'm looking at first name, last name, date of birth, gender. Gender is actually a moderate problem right now, just to be honest, right? So there's birth and there's observed and there's politics involved with that too, right? So it's more difficult than it seems. Thinking about ripping it out as a criteria, actually, quite frankly. And some use social security number 4, SSN 4, all these other things go in. But when I feed you that data, I don't know if you have it, right? And the normal response in Interop is yes or no.
Yep.
Right? It's I have that person and uniquely identified them, or no. And the no could be because the data doesn't match, or because it was ambiguous, or it could be a whole bunch of other reasons. So we do have a problem here, right? And so when we think about QHINs, and I get asked this question all the time, what about a national identifier? I'm like, hell yeah, right? It's not, I don't want this as a differentiator. Like I would, yeah, well. Farzad gave a very colorful response to this a couple of years ago when he was head of the ONC. I can't use F-bombs here, but he got away with it in front of 1,500 people at a Medicare conference. He was just like, no, and stop bleeping asking. Like we're not getting there. So it is still a problem. The best we can do right now is expose what our logic is and be very, very vigilant on all the support tickets, whatever, to trap this through. We find that sharing patient identities kind of one-on-one to say, this is why this happened, helps a lot. Actually Epic and CommonWell went through about I think it's a 6-week exercise on 2 practices that there was a major matching problem. And what was the problem? The provider had just recently onboarded to CommonWell or re-onboarded to CommonWell and didn't do a backload of their MPI. So all we have is the last 18 months of identities. So all these things weren't matching that were before 18 months plus 1 day. All that stuff was dark until we brought it back again. So you find out these weird things only by looking, unfortunately, by transaction.
One last question. Okay.
Well, specifically, this question is for Dr. Blythe. I'm looking from the consumer point of view, the patient side of it. You actually have a doctors participating in your TEFCA. I suppose they started already using TEFCA. And are they interested in promoting consumer patients, how to get the digital medical record from them and aggregate the data they get from the labs and other testing places, diagnostic facilities, and interact with the doctors? Are they encouraging them? Are they interested in it? Are they excited or not excited? Or they want to keep them away?
Yeah, so you're asking if the consumer facing company that is connected to our network, what kind of responses they're getting and whether the providers are comfortable giving that? So you're asking?
Yes.
Okay. They're not. So, and this is individual access service, and you may want to speak to this because this gets to the provider's comfort in giving the data out to a non-provider, and how can they trust that it's going to the right patient, and if it's not, will they be in trouble for a breach? So there's a lot of concern around that. There is less concern as we move to FHIR. You've heard about FHIR because there's going to be a standard that will have to be utilized by 2026 that gets into the registration, authorization, and access. It's called UDAP, and others here that understand it better than I do. But once that gets in place, I think that things will improve. But that's a little over a year from now. Epic is doing something to satisfy their providers that goes a little beyond what's required under TEFCA. We're working with them on that. That company that I talked about is going to make that compliant. But again, it's the provider organizations that feel comfortable allowing this for a non-treatment purpose. I mean, you want to follow on that at all?
Final quick thoughts here?
Yeah, I think you hit the nail on the head, right? I mean, apps are not covered entities. And so when providers have to disclose data to non-covered entities, there are concerns from the compliance teams. And so I think TEFCA does have some advantages where these apps sign on to agreements that get them to follow the guidelines for the covered entities. It still depends on who you're talking from the compliance perspective. I think to John's point, there are some more recent advances in the individual access IG implementation guide that allows patient control to release their data through a portal. So for our example, patients can now go into MyChart and be able to say, yes, I'm authorizing Apple Health or this other entity to release my data. So there's a sense of security that the right patient's being matched, and it allows covered entities a little bit more comfort.
Yeah. Steve, closing thought?
Yeah, I think IAS is one of the most exciting, most visible, most talked about things that TEFCA enables. Actually, we probably still too early in IAS adoption. But I noticed from my experience, there are two types of people that don't care about their clinical data at all. Younger people that tend to be more healthier can care less, whether or not they have their Fitbits and stuff like that, how many steps they walk. There are also differences between corporate physicians, employed physicians, large health systems, and ambulatory physicians, right? Obviously, there's a tiny minority of ambulatory physicians that operate clinics and things of that nature. Depending on state, they're a lot more interested in sharing data with the patients than larger health organizations where rules are very different from that. So using those guidelines, we hear different levels of feedback. We absolutely need data, and we don't really care whether or not we share this data with patients. But I think TEFCA is at least designed on the right track with the IL2 measures in place right now, and we're actively working. And as Mickey keeps saying, we have to meet the industry where the industry is today. Right? So there's private sector, there's compliance, there's liability. I'm very happy to participate with all other QHINs here in advancing IAS. At least we're meeting halfway. It's not going to be ubiquitous for the next couple of years. Hopefully we're on the path there to actually establish IAS in the way regulations are written with no special efforts, right? Today, there's still a lot of special efforts and a lot of friction points, but at least we're making progress on IAS.
Well, we have.
Do they feel the importance and eventually, if not now, in a year down the road, the value in educating the consumer, the patient, helping them to how to upload the data and communicate with them? Do they believe in it, improving the quality of care at that point?
Some yes, and some are not focused on that. So depends on the organization.
Let's hear it for our panel.
Can't thank you enough, Kevin, for this. I'd also like to thank John, Paul, George, and Ringo for doing a very nice job on the QHINs. Right. You guys decide. Two other points, and sorry, we're going to plow through because that's the best we could do. If you need a bio break, that's great. Do not go out there and eat lunch now. Okay, that comes after. It is set up. One is, unfortunately, Virginia, there's not going to be that singular, vehicle in the near future that helps. Okay, no, not for the foreseeable future, not this year or next. But there are a lot of different tools, a lot of different capabilities, utilities that we're going to have to use to go from a thread of connectivity that we have today to the quilt. Question will be which ones for whom. And it does sort of remind me of marketing, believe it or not, and market segmentation at Xerox, understanding different scenarios, and we'll have to figure out how to do that. But now quickly, we want to get to the next panel. And I would really, really appreciate if Tom would come on up. So Tom Hallisey, Digital Health Strategy Director of HIMSS Health Association in New York. He spent his entire career guiding healthcare organizations to improve operations and care quality, effective use of IT, including being a CIO at Cayuga Medical Center in Ithaca. He's currently HIMSS Head of Digital Health Strategy, a trustee on the board of Albany Med Health System, and adjunct professor of SUNY Downstate. Wow. Formulates and executes HIMSS state and federal HIT regulatory and legislative agenda and provides education and collaboration to New York health systems. A lot of people rely on Tom. His work includes guiding statewide collaborative efforts to improve care through tech in areas such as virtual telehealth, cyber, and clinical informatics. He received multiple degrees from University of Connecticut, where I'm sure he had the opportunity to see many amazing basketball games. Unfortunately, many were victories over the #1 college sports team in New York State, guys, the Syracuse Orangemen, right? Okay. And Tom, take it away.
Plenty enough. Too much. Done? Yeah. So thank you, Al and Tony, Al, for doing all the work, getting all this up, inviting me, and Tony, all the efforts and the food, which we promised not to keep you too long from. So just a couple quick remarks. We certainly heard this morning that any interoperability issues aren't from lack of effort. In fact, they aren't from lack of options either. We've got lots of options. And what we heard a little bit from Virginia was maybe too many options, maybe too much complication. It's confusing. There's a lot out there. And in our last panel, what we really want to look at is where the rubber meets the road, where the magic happens. Do we get the value? And the last panel began to note that, but we heard a lot of tech, we heard a lot of policy, and moving data around alone doesn't accomplish anything, at least not until our AI overlords take over and run the force. But at the moment, we still have to get that data down to the actual clinicians and see that value. And is it improving care? And so I'm honored to moderate the panel of providers and from provider groups where we'll take a look at that. So with me today, I have Lisa Nelson, who is the Associate Vice President and Chief Application Officer, almost said academic on my brain, at the University of Rochester Medical Center, and is a pharmacist by trade and brings that knowledge to her role. I also have Patty Cortus with me today, who is the Associate Chief Medical Information Officer at Mount Sinai, and also a physician assistant, still practicing, and past president of the New York State Society of PAs. Notice they're all clinicians except me, because I also have with us today Dr. John Travis Scassi from Weill Medicine, where he is the Associate Chief Medical Information Officer, and also still practicing internal medicine. Keep standing. So no, I'm joking, Tony. I'm fine. I'm still much younger than I look. No, I wish. So I think to start us off, we really we want to hear from the provider perspective. Where do we stand now? How are we using this? What value we're getting? So I'll leave it that wide open and we'll jump right into that. At least if we could start with you. University of Rochester.
Oh, see, I thought I was last on the list, so I'd be last on the
well,
question, but that's okay. So Tom and I work together, our partner on the HIMSS EHR group, and so we've been talking a lot about this. So thank you for those of you who participate in that. There's too much data. I mean, again, as a practicing or as a pharmacist and someone who's now in charge of the EHR, I want as much data as possible. I think data is good. We're doing some stuff with AI. But I will say, besides pipes, I actually see it as a multi-lane highway. So I was driving in from New Jersey today, not very different highways than we have in upstate New York. But we're going to need to connect. You know, we're in Rochester, we're very fortunate that the major health systems are all on Epic. So, you know, one might be inclined to say, let's just exchange with each other. But we also have a very, you know, very engaged Rio and HIE, and then we're exchanging all over the place. The thing that bothers me is that we have all this information coming into the EHR, and what I hear from clinicians is it's just too much, and it gets to be noise. There's duplicates, and it's not all helpful. And so, how do we, you know, now start powering to use AI to make sure that the right information shows up in the workflow at the right time for the person who needs to make the decision? Because just putting it on the health systems or the people who are, you know, with the setup to quote, make the decision, I don't think is where we're going to get to where we need to be. So we have a lot of data and a lot of cleanup to do.
Absolutely. Thank you. And Patty,
What was the question?
really, what's the current state? What are you using? Is it bringing value?
I mean, it's messy. It's very messy. And, you know, that's coming from a system where we tried very much. I think Paul mentioned, you know, the frankly lowest paid people are really left with a lot of responsibility. And that's unfortunate. We actually at Mount Sinai a few years ago, because we realized why is it that we can't really take care of our patients with the data that we should know, right? Patients don't have it. And only because we're moving to this value-based care and moving away from fee-for-service, we started to pay attention and we realized, oh, we're not consenting patients. So therefore we don't have their data. And no one knows this stuff, including providers. And that may have been 10 years ago, 8 years ago, 5 years ago, still today. So yeah, providers, I mean, I talk to them all the time. I am too. Sometimes I can't even tell where something comes from. And I should, but we don't make it easy. So big word, messy, you have to untangle it.
I can remember being in a conference, like like an internal medicine meeting at Cornell, and someone said, "What is this information in Epic? I don't want it." It was when we went live with RX Hub, and it was just fill history and the patient's medications. That was kind of like the first time in which actual external data was available in the chart, like kind of seamlessly there. And she's like, "Don't ever send this to me again." But anyway, it's gotten better. Like I do agree it's a little messy, but I actually, I've been doing Epic stuff for 20 years now. I've seen how far we've come, and I see how far we can go. I'm hopeful that some of the technologies that are coming down the pike can help us ingest the data a little bit better. I was actually going to make a joke about how it's nice to talk about something other than AI, but it seems to crop up in every conversation that we have. But that said, I think we've actually done a better job of coalescing the data, at least in Epic, and like I think we're all Epic folks, in which like at the very beginning we segregated care everywhere in its own tab. Providers had to go to it, and that was because we all had the mistaken notion that we want it to be walled off. We want to know that it's there, but we don't want to be able to, we don't want to see it unless we have to do it. Unless we want to. But now we've actually integrated like outside encounters into the in Epic, there's something called chart review. There's an encounters tab. Oh, you were seen at Mount Sinai 2 days ago? Wait a second, why didn't you mention that to me? Like, how'd you know? And sometimes people get a little freaked out, and I get that. But it actually is helping us concatenate the data in a more seamless way. It's the way we think, it's the way we've consumed the data. We're doing that for radiology, for labs, that kind of thing. I think that's all a step in the right direction. If you expect the doctor to do a search to go to someplace else, they won't. If you slide it into where they're normally consuming the data, it works out better. But we are now getting it's just too much data. Previously, I would know that the patient, saw the cardiologist, that kind of thing, and they'd tell me if they saw someone else. But that was kind of a snippet. Now we're actually really showing it to like our providers, and some people love it and some people hate it. It's also interesting to see the the residents. Like, so like after this, I'm going to go teach the residents. They're the folks that actually are the ones that, like, let's face it, take care of the patients in house. And they're the ones who actually are the persons who really are consuming this data. And they've come a long way. And it's actually very impressive to see how well they do with it. So I'm hopeful that the digital natives, like the folks that we're also doing downtime drills. And like the other day, someone's like, what's a paper script? I'm like, oh, bless you. And so like we've kind of come full circle in which like the people that used to know paper are now the ones that are now in the minority, and the people that have never seen a patient without an EMR are now becoming like the dominant people in the community. And it's just interesting to see how that's coming about.
Yeah, and those expectations are higher than they've ever been, of expecting not just the way that we're all consumers and, we can schedule a flight on our phone, we should be able to schedule a flight. And the expectations of the younger providers and nurses are really raising that bar, and they're asking good questions.
Absolutely. And the patients as well, as we've heard a little bit about. We're all consumers, including the clinician here of this data. Dr. Gassi, in particular, I think you have some bit of numbers on, if you could tell us, not the detailed numbers, but where the data is being ingested from.
Okay.
So just to get a feel for the use.
Well, like, I'm glad I looked at our interoperability dashboard this morning. So last month we sent out 3.5 million records. We received 2.5 million records. About 80% of the ER visits and inpatient visits, someone actually looked at the external data. Now, in terms of actually reconciling the data into the chart, like that's where they bring in the meds and bring in the allergies and bring in the problems. That was about 20% to 30%, depending upon the area. But hey, not bad. What people also find fascinating is that our number one trading partner aren't other Epic institutions. They're actually external. So we love Care Quality, Health, like all the other networks, we actually do a lot of volume with them. And so it's actually impressive to see that greater than 50% of our volume is not within Epic. Now, 10 years ago, that was the exact opposite. But things have evolved where like the other networks are now bringing in a lot of volume for us. And that's amazing to see.
Anybody else have any thoughts on that?
We actually had a fun little project a couple of years ago with and there was a lot of, I don't want to say maybe around reconciling, auto reconciling, right? And you're a pharmacist, so I know that. But everyone wants it easy, right? And it was literally having to see auto reconciling might sound easy, but it's actually very. So this is the opposite of AI. You need a person with some judgment to say, yes, this makes sense. Yes, I'm going to reconcile. And now it's going to be. So as far as we get to how many external sources of data come in, we still need that kind of balance. I think.
Yeah, I mean, we did it around COVID. I mean, we brought in COVID vaccines, but that was actually a really eye-opening experience, at least for us, in which in New York, there's a lot of people with like the first letter, the first name, and then the last name and the birth date. Like the city's CAR, like I love them. I'm not throwing the bus, but their matching is a little leakier than what we're accustomed to. And so we had a lot of people that would show up to our mass vaccination sites and be like, well, you got your vaccine last week. The hell I did, we're like, well, it says here that you got on your right arm from that, like, it wasn't that Amy Wang, it was another Amy Wang, who happened to be, same birth date, same everything. So they matched, they sit in, and this is at the height of COVID, in which we're trying our best to do our do mass vaccinations. And so we brought into the system, but that really exposed what can happen. And this thankfully is lower stakes because the patient can actually tell us that this is wrong and we could correct it. But it just exposed like how leaky some of the matching algorithms out there are.
What it exposed for us was how we weren't, because of the consent issue of patients over 18 needed to consent to share vaccine data.
Even in a public health.
Yes.
And let's just face it, that federal government doesn't do us a great job when they name these vaccines, right? This year, if any of you are paying attention, the flu vaccine, it goes from monovalent to trivalent to quadrivalent, depending on, and they don't all match, even though they are appropriate for the right year. And God forbid that somebody thinks that they're supposed to only give half of a quadrivalent versus, I have actually had that call in my role as an IT person. So again, I think, poor Tom has heard me kind of pontificate about how the state immunization registry could probably help us with some of this, but we won't go there for now. But I do think, right, auto reconciliation, while it seems like a great idea around a boardroom, and especially for people who are complaining, with less clicks, you only have to give somebody the wrong vaccine because of how it came across or the wrong patient. And then all of a sudden it's a lot of cleanup. And if any of us who've ever had to clean up our allergy records or anything in the EHR, that manual cleanup is very painful because our great colleagues on the interface side can't always just clean up. It's very hard to clean up data on patients, real patients, like patients in the same, once they have a record. I say that all the time. It's easy when you start and go live with Epic, but once you're actually actively taking care of patients, we don't get to do a Control-Alt-Delete and wipe the record and start again. So it becomes a little bit of a challenge.
Yeah, we heard that a little bit in the last group, that check your data, check your own data. And we know that's an issue. And I like the way he put that front desk person. But even when it's, a nurse that's doing that, their primary focus is that immediate care and not the data governance that then has to come into play. And all of you have to run to get this in place. I wanted to follow up a little. Everybody, I think, mentioned feedback from the clinician themselves and what they know or what they understand. And I know in my MHA class that I teach, there are a lot of physicians. I don't see Todd here, but Todd and Harold have helped and talked to Interop to my class. And we get a lot of feedback with, I work at, and I won't name any of your institutions. I didn't know any of this happens. So just a question of what level of education you think they should have, or do they have? And I see some grins, but just some ideas on what you think there.
Well, we try our best. But I'm a physician as well. And so like I did my annual hospital training. I get assigned it twice. I have a Cornell account and an NYP account. So I'm considered two doctors. Yeah, anyway.
You gotta merge your account.
Yeah, it's fine. It's fine. But I mean, I've got all that. So I've got that. And then I've got there's a mandate for pain assessments and pain management and blah, blah, blah. And you add it all together. And it's hard because you're also trying to see patients. And we want, but my goal is just to nudge folks to kind of let them know that it's different, let them know it's available, put it into their workflow, make the right thing easy, make the wrong thing difficult, and try your best, not necessarily to get in their way. It's otherwise, if people say that's a training point, if there's a lot of training points, then your intervention is not going to do well. You really need to make it as simple as using your phone. Otherwise, it's not possible to get people to do it at scale.
That's a great point.
And just that, so we actually spent considerable amount of money training, again, our front desk staff, but also our clinicians around what interoperability is, but we didn't call it that because it's too big of a word. Just like, hey, you want to see data on your patients? But also your patients are going to come and ask you questions. You should probably know the answers. And again, this wasn't necessarily because any clinician asked us. It was back when we needed to exchange data and care coordinate better. And, we were moving, it was the district days. Okay, I don't want to say that word too much, but yes, it was during district. A lot of us have scars and pains, and that's why I don't like to mention it. But the point is, it was good, right? Because it made us really look at why aren't we doing better, right? And all of these targets that the state set. And when we looked under the covers, again, at least at Mount Sinai and our 186 partners, we said, oh, we have 52 different EMRs. There's just no way that we're going to be able to know what is going on with the patient. And we're responsible for all of that. So we embarked on education, and we created videos. We created, you know, a website on our internet, and we still have it. It's a little outdated, but that actually moved the needle for us. And it has been really the backbone for a lot of the work that we are now doing. You know, that's okay. Everyone forgets how we started, but we're a lot better. That's one thing. I want to shout out a little bit. I'm not going to call their name, but we recently went live with something that, I mean, we don't always get good calls from clinicians. You know, it's always like over there behind the curtain. But we actually just went live with an Epic with a little widget. I'll call it a widget. It's like saying, I know you're going to be jealous. Oh, you might even have it too. But it's like saying, what is the thing that we say in IT? Please don't say it's a glitch. Glitch happens in the matrix, right? Anyway, so it's a little widget within Epic in chart review that you can actually go out into an HIE's portal and see social determinants of health data. This is amazing, but what actually, and we don't have a lot of data yet because it's still just beginning, but we're trying to get all the information that we can about patients. But what came with it, and I was like pleasantly surprised, was that access to the PMP. One click. That does not happen. If you're a provider, that does not happen. It's like you always count.
That was access to the PDMP, the iStop.
Yes,
correct.
the
But,
iStop.
but that's because your HIE has set that up.
Yes.
That's not because, so for those of us whose HIE has not set that up. Right, so that's a great example of how everyone along the way needs to understand the data back and forth and be talking about that because, right, that would be a huge win. When I brought it back, they're like, oh, that's on our list way at the bottom.
Well,
So
it took us
maybe,
almost 2 years.
maybe
but-
Al and I'll have to kind of push the, you know, but yeah, no, I think that's a great example of like, and when it works great and it's seamless, the wow moment.
Yeah, no, it's a great carrot to get people to use it. The person who implemented that at our place is sitting in here. So yay, thanks, Karen.
So,
But anyway, yeah, I mean, like, but like when providers, when there's a carrot for them to actually like our adoption of that widget, we can call it concise.
All right, fine.
Their adoption of that was okay, but now there's another inducement for them to actually go there and explore it, and they're using it more because like it takes away another burden in which like they previously you have to log in once a day, but then it'll do the query for you. So like, oh, I can start going there, and so it's an inducement for them to like go to that part because there's more of a reward than just data. It actually like makes part of their lives easier.
And just to be clear, this is a Fire API app linked into the EHR that goes out to the New York State iStop BDMP to do the drug checking that's required for an order. So it's a great example of interoperability of, as we heard earlier, finally moving towards Fire. And so it's a tiny example really, but it's always the little things that they love the most.
It's the little things. I mean, when we presented it and we went to a lot of the different councils and we did a road show, you know, because that's what you have to do so people know that it's there. You can't just send out a tip sheet, even though we still make tip sheets. Okay, that joke landed poorly, but we still make tip sheets. There's still the question of, yes, but what about the rest? You know, the patient's travel. It's like, oh my God, you're never, you know, and that's fine, right? We need to get continuously pushed by our providers, right? Because, I mean, we're here to serve the providers to take care of the patients, right?
So when we talk about education, we really tied it into opening up our e-check-in and allowing patients. So we have about 30% of people who are checking in on their phones and really trying to say that you are a partner in your own data. And getting people very comfortable with the social determinants of health questions that we are asking to everybody in all facets. So not ambulatory ED, all inpatient care, but that it's a partnership and you're responsible as the patient, as that, you know, other person kind of monitoring that care. And if you see something, say something. Now, I will say people are very happy to tell you when it's wrong, which is fine. And we want them to be able to say that because that's how we figure out that there's things that are broken or that, you know, there's MPI loads that are, but it was around that. And then when we started engaging the patients and the residents were also a big piece of this, all of a sudden people were like,
tell me more. And kind of, using some of our M&M and some of our more academic conferences to kind of bring in some interoperability good catches where it's actually made a difference in patient outcome, but also some near misses. So we tried to kind of package it that way.
I do want to go back to one other thing because, more data isn't always good. And I think we've moved the needle on this as well, where a lot of providers, physicians, especially, either within our own network of hospitals and practices would say, you're making my accountability higher, my liability higher, because what am I supposed to do knowing that the patient was admitted to an ED or is in jail? What am I supposed to do with that, right? So we have gone from too much data, I don't want to know, please don't tell me, to options like, okay, then subscribe to them, right? So allow the subscription. We have a menu. Or, okay, if you don't want to know, that's fine. You don't have to know. But at least the option is there. We have moved. I haven't heard it as much recently of, please, just don't tell me.
And I don't have a small hospital up here, but I wish I did, because I would give a shout out to the HIEs across the state that look to add some of those services, because as larger health systems, you have that menu, you create that, you ingest all of this and decide, as Travis mentioned, how they subscribe to it, what given clinician wants to pull in. That doesn't all come naturally ready to roll.
It's not lost on us that, we are lucky that we are funded in some ways, but we're never funded enough. We never have the right amount of resources for what we should do, compared to our size.
So to go back to, and by the way, anyone online or here, please feel free to ask questions instead of having me ask them all. But I just wanted to bring us back to what we heard all morning. TEFCA, mostly TEFCA, but we heard from the QHINs, the HIEs, QEs, whatever acronyms we want to throw around. So what did you hear that you think will add value? Or what do you think was missed that maybe we should be doing? I'll throw that out to anyone who.
I'm on the board of the eHealth Exchange. I'm on the coordinating committee. So putting that aside, I think we all need to do TEFCA. I think that it's going to be very confusing, more than it is now. Forget about providers, but even just leaders and decision makers. We need to educate on, sign up for all the QHINs if you can, right? But, don't choose one over the other when you don't understand it quite yet, or maybe sign up for none until you understand it more. But, because each one will, as they said, will bring a different flavor. And we need to kind of move together, because that's going to be what's going to make the difference.
I think that was my multi-lane highway. Yes. That's kind of what we're doing. We're signing up for, some is good, more is better. And then obviously partnering with Epic, because again, I think we at least, we do a ton of exchange through Epic because of where we are in the state and the fact that, we have a lot of people referring to us. And that is actually the way our providers would rather get it, because they feel like that, bringing in all that information from another Epic visit that lands properly just makes their practices easier. But, until we kind of sorts itself out, I guess I don't want to exclude anyone at the party. You mentioned something else about doing drills, and I will say to everyone here, I do think there's a huge benefit to our HIEs and you all have our data, that if we have an issue and we are down, how can we partner better with you giving us and partnering with us in almost like what we did in COVID, in a 72-hour, let's get everyone signed up and get that data back into our paper charts, because that's how we're going to be able to take care of patients as we as IT people bring up our systems. And so I do think that there is a missed opportunity maybe of quantifying that and standardizing that we all could use as we talk about some of these new regulations with cyber attacks, but just the fact that that's something we deal with, the cybersecurity and cyber risk every single day.
And actually, that reminded me of Virginia. You want one pipe. That scares me because we need to diversify. I mean, but there's a balance, right? So you don't want 600 pipes, but you don't want one or two. And because for us, what happened to us recently, I won't name them, but they might be a big SureScripts company. They actually gave us very little notification that we weren't going to be able to use them. Like, what do you mean? Please give us more time, right? So again, you don't want to put all your eggs in one basket.
Travis, any thoughts on the good or
Well,
bad today?
Well, no, what I mean, looking forward to, like, so I'm like, I don't take a lot of new patients. I don't have a lot of bandwidth, but I have a new person who's coming to see me next week. She had a stroke and is going to move in with family here, needs like some care. And I got the paper records. I couldn't pull them down from the hospital that she was at. And so I'm looking forward to greasing the wheels of like, finding those.
That means you had a fax machine.
Yep. Everyone talks about like there's Axe-the-Fax and there's all these things. I think it's a cockroach. I don't know when it's ever going to actually fully die.
I agree.
But yeah, there's still blind spots, and I'm happy. I'll be happy when like if I never have to have another paper chart faxed over to me, that'll be like I thought I escaped it, but
What about e-fax? Does that count?
yeah, well,
And if
yeah.
you think it's confusing to us, imagine the patient who's heard all of these things that are going on. Imagine if they heard this whole morning and then yet there was a fax. How could that possibly be? And I see a question.
So, interoperability, and I'm probably one of the older ones in the house, but I've been at this for a while, and my interest always has been the patient in terms of benefit to the patient, and I think we planned this, and I think it's a great event. Obviously, yeah, I put my 2 cents in. All that is good, and I heard everyone talk about the providers and the data and who has it and who doesn't has it. And my bottom line is, as your organization, are you measuring the impact that what you are doing, and when I say you, is not in general, all these things that we are doing, are you measuring the impact that that is having on patient outcome in small numbers, big numbers, or you are not? You may not be able to answer that. If you are, is that part of your performance improvement, the gadget, widget? Now that you have that and you see that as a wonderful thing, do you tie that into how it's benefiting the patient outcome? The providers are probably going to be happy, but how does that specifically benefit a patient, a day in the life of a patient?
Can I take that?
Great.
So I love that question. So a few things that we've done at Mount Sinai. So because our patients see the notes and the results sometimes even faster than the providers, we've actually taken a huge initiative over a year now. We call it the FAIR Project, where we look at stigmatizing words, and sensitive words and never words and things that can hurt the patient. So that is a huge focus. It's led by our health equity partners, and we have health equity in our technology group as well. So that's one aspect, right? So as we're putting data out there, it has an impact. Sometimes it's qualitative. You can't always measure it. Or you might want to measure it in patient complaints, but you don't really want to do that. You don't want to wait for the complaint to measure it. The other thing that we've done recently at Mount Sinai is we've applied for a grant from AHRQ for patient-centered data using some of these tools, some of the QHIN tools. Somebody asked, well, what about the patients? How do they have access to whatever TEFCA brings? Well, it's in the research side right now, I think. I don't think any of us have figured it out, but at least we're asking the questions, and we're going to put some time and effort to learn that, because yeah, the patients, I mean, we all talk about data, but it's the patient's data. I mean, I know we say that all the time, but do we really believe it? It's the patient's data, right? So there's been a lot of controversy also with third-party apps and, going through the patient who knows the least and understands the least. I mean, we're all patients, but we're not typical patients, I don't think, right? So when you have that kind of vulnerability, I don't want to get into controversies, but I do agree with some of the things that have been done there.
I have another question over here. One over there and one online.
Hi, hello. My question is, what do you think about organizationals' authorization policies and how they affect clinicians' ability to receive the information they want from outside sources? Basically, opt-in versus opt-out workflows for interoperability, and how can we ease some of those restrictions potentially with our compliance and HIM groups? New York being one of the most restrictive states in the country when it comes to this kind of thing.
So yeah, the consent process is very challenging. I think we talked about, I'm looking at, our colleague in the back there about, just having a universal, especially as we all become more and more connected and our patients are moving. I think a universal consent would solve a lot of those problems. Because I think the patients are very confused when they have to sign the same form, and then they start asking questions about, well, why am I doing this? What does this mean? I already signed this before, and it's awkward for us. It's confusing, right? We're all semi-confused, and then trying to say it in a patient-friendly language in a way that doesn't sound like, we're selling your data. I also think, organizationally, Change Healthcare, trying to explain to people, even within our own organization, I didn't realize we were sending that to Change. I'm like, I didn't either, because we signed the BAA, we didn't even need a BAA. I think as we're starting to look at our structure and who we're actually sharing data with, not just a one-time when we're buying the application, but all the way through and on an ongoing basis, we're starting to realize, right, we have data, not only what we're sending out and what the patients agreed to, but then once it's out there, who else is seeing it? And that we actually are losing control of our patients' data in a way and it's valuable, and people are paying lots of money for our patients' data. So obviously, that to me says, okay, then we need to go back and relook at that, because there's a value there.
But I love that question also, because the providers are confused. They think that we're saying you can't see that data about your patient. It's not us, right? I think we're still one of only 7 states that are opt-in, right? Like, we're shouldn't be doing it this way. And David knows that. He's fine.
Yeah, and just to be clear, David and his team and some of us on different committees are looking to change that.
Yeah,
with
and,
the HIEs.
and we need to. But that, again, how do we educate our providers that it's really because the patient.
The one back here was just asked up front.
Oh, okay. So I think I first had a question over here.
I agree with you, your opening statement about how there's too much data, and I work in data, so but I still feel that way. But if we were to refer to it as information that helps the patient rather than patient's data, we would think totally differently about it, right? But it's not all information. And so I think that behind the interop problem, behind the data collection and aggregation problem, lies the data usability problem, which is really where we're at now. And I was thinking about what you were talking, you spent at least 10 minutes talking very positively about something that no one used the word for, which is user experience. Yeah. User experience in the systems that providers use. And then you said, those projects are always at the bottom of the priority list. I think that that is going to be way more important than AI in the next few years in ensuring that providers can actually make use of the data. I wonder what you think.
Excellently said. You said it great. We can end now, Tom, and all these poor people can go eat. I mean, I think that's a really interesting way of looking at it, and it's right. It's spot on.
Yeah, and So like one of the things we have our upgrade Saturday. I don't know if you
Us
guys
too.
do. Oh yeah.
Yes, look at that. What a
Typically
coincidence.
on daylight savings changes, that's a perfect time to do your updates. Anyway, one of the things we're doing, we're actually trying to simplify Epic. So we're collapsing the plan and wrap up tab in the ambulatory visit navigators and stuff like that, in which we found that people don't like clicking around. We were like, okay, we're not going to make them scroll, we'll make them click. And now we're finding that they don't like to scroll. But so anyway, we're also doing something where the system looks at how you're using it. And if you don't interact with that part of okay, I do my smoking history, not in the vital section, I do it in the history section. So eventually the vital section will just have the stuff that I interact with, and the stuff that I don't, I can still, if I want it, I can still push a button, it'll show up, but it's going to simplify it a little bit so that I don't have as much cognitive load when I'm interacting with it. So the user experience is something that's important. I think that we're trying. It's just one man's treasure is another woman's junk, or what have you. And so you try to take something away and how dare you? And but I never look at that. So yeah, I think every upgrade is my time to move the cheese on everyone. So we'll see.
And we have gone from a triple aim to a quadruple aim with
Win troop.
oh,
It just went up to 5.
oh.
Health equity. Health equity.
But of course. But the fourth item there was, of course, that clinician, and not to upset Travis and bring the AI into it, but I think AI will be a part of it, and certainly is early on.
Yeah, but last night, I mean, how many? I don't know. Did anyone see the Whisper, the concerns about the Whisper technology, writing notes and how it hallucinates?
From AP News.
Yeah, that was my evening. Okay, we have a very good relationship among our ACMIOs in the consortium, and that's what we were texting about last night. Oh my gosh, thank God we didn't go live with that one. And but I mean, these are the things that keep us up. We're okay, this is great, we're excited, and then you're you read some of these, yeah, it's one in 1,000. But wow, that's actually more prevalent than I thought. And we talk a lot about that in our EMR group, but that's also why we're starting a provider AI group to really discuss locally, because there's a lot of systems already using that tech, and we need to discuss that. And it's a cool party trick. I mean, let's face it. But then well, anyway, I can talk about our evaluations of them. Yeah. But some of them are it looks really cool until you actually try to use it, and then it's oh, this isn't exactly what I thought it was going to be.
So I think I'm told we're out of time. I see a lot of questions, so I know I'll be around. Hopefully others will for lunch. Maybe you can ask questions while we're chewing.
And feel free to send us questions.
So thank you all on the panel. Thanks, Al.
On the mic.
Al, turn on your mic.
A little bit of wrap up and some thank yous. Only minutes. So first of all, we heard today there is no silver bullet yet. Virginia tasks us to get there, and we're all going to try. Reality is it's going to have to be viewed differently by every group and every type of organization. We want to go from threads of connectivity to a quilt. Who needs a quilt? Well, providers need a quilt. And today is largely health systems. We could probably do a mini version of this for FQHCs. Who here works a lot with FQHCs? Anybody?
How many did they
Yeah. Or nursing homes, or specialists, or public health, as was discussed today. All have their own view of the challenges and the opportunities here. Public health, a lot of what David told us about is going to be used by New York State today, but there's also community public health, and the 1115 waiver is a big part of that. Pharma, devices, AI solutions, and payers. Each of them has different use cases. We heard some of them today, whether it's point of care, transition of care, Pop Health, et cetera. We're not going through this, but it's thinking through from each of those providers, each of those types of organizations, what do they need interoperability for? In particular in public health, whether it be the community or the state. There's a whole plethora of tools that are available today, and you need to understand the capabilities that your organization or any of these organizations has in place. Like Jordan DeMarco, you know, he really delivered on systems structured thinking. It has to start with, what do you have in place? What are your requirements? And how are you going to get from here to there? You have a whole bunch of tools to choose from, and there'll probably be more that come around. Each of the QHINs is different. That was an excellent discussion. I learned, everyone learned. I hope everyone learned something today. So what kind of quilt are you going to design to help you accomplish your needs? It'll take a while, but I hope that we'll be in the continue New York State's efforts to help us do so and provide more tools for us. So I want to thank everyone for participating. It's a long day. I know you're hungry. We do have lunch, but Tony's got some housekeeping to thank us up with, and thank you very much.
Thank you, Al. Appreciate it. Real quick, Dr. Prasad, would you stand up, please? I would like to point out to everybody, Dr. Prasad's idea was to do this today. He came to our committee, our programming committee, put it out there. I'd like to have a nice little round of applause for him. He's also part of the organization called HEC, the Health Executives Club in New York. Marcia and Dennis Conway are part of that group. They help us be able to fill the room, which is terrific. And last but not least, we can put up the sponsor slide. Yeah. Oh yeah, we'll get. What I want to do is, everybody, before you leave, go out there and hug one of those sponsors, because they gave us enough money to get all that good food here. Okay. And thank Microsoft for offering their facility to us. Now, if everybody knows my motto, it's no eating, no meeting. So we have that in a couple of minutes. And then last but not least, we're always looking for new volunteers to join our New York HIMSS group. There are plenty of opportunities. Like Dr. Prasad came to one of our meetings. We listen to good ideas and we expand upon them, and then we go out to our community. And I thank folks like Tom, folks like Al, folks like Virginia, who then extended themselves to be able to put it out there. And also our nursing committee, where when we mentioned to them, Olga, please stand up. There we go. We got everybody involved, and we put it out there on social media. And anybody who didn't sign up, they're the losers. We're all the winners here today. There we go.
Not to join HIMSS state chapter, $39. If you're a national member, it comes with it. For $39, you would have saved $25 today. So please join.
Okay.
Like that.
So again, we have food outside. Continue your networking. I'm sure everybody's got a few questions of some of the other speakers that are still hanging around. I'd also like to give a big thank you to all of our moderators and panelists. Great job to all of them. Don't want to have to repeat everybody's name because I'll probably screw it up anyway. So there we go. Everybody have a great day. Oh, 1 second. Put the slide up. I want to tell you something that we do each year, at least one of our events. We take the extra money that's why we charge everybody a couple of bucks. And we make a donation out to a 501c3 healthcare organization. This year, there it is. And I think David Fripkin, yeah, we're trying to get him on the line. He'll just say a couple of words. But as you can see, Blaisdell Children's Hospital cares for patients with emerging medical concerns, okay? Everything from tuberculosis and polio in the early years, emerging medical disorders today. They're a great organization, and they help those that are in need. From what I understand, they're a predominant Medicaid hospital. Okay, so every dollar that they can get provides care to someone who is in need. And guess what? We're helping. And all of you folks out here today helped. And I want to say thank you to every single one of you folks today, because that money is going to go to good use and provide somebody maybe not to the individual that needs the care, but maybe to their family to know that there are people out there that care and want
It's
to be
okay,
able
well,
to
I'm
help
on,
them.
so it's open.
He's on. David, you
Hi,
got the
I'm
floor. Give us a.
Thank you. I'm David Friedkin. I'm the administrator of the long-term care unit at Blytheville Children's Hospital. The leadership wants to thank HIMSS and the HEC for the donation that they're giving to the organization. The children are the benefactors of these money that you're giving us and will benefit from your generosity. Thank you so much for all you're doing for us.
Thank you, David. It's a pleasure on our end here, everybody in the room. Put the money to good use, help somebody out, and hopefully one day you and I will get a chance to shake hands. Okay?
Definitely. Thank you so much.
Have a good day. Everybody go enjoy some lunch. Thank you. Go.
Well, yeah. Oh, no.